All right, committee, let's come back to order. Next thing on our agenda is a topic on white bagging. We're joined once again by the Department of Health and the Department of Insurance. And now we're recording. With that, Mr. Fuchs, are you presenting this topic? Welcome.
Good morning, Mr. Chairman, Mr. Co-Chair, members of the committee. My name is Franz Fuchs, Policy Analyst, Department of Health. Here to provide a brief overview of white bagging and brown bagging. These begin on slide 20 of the omnibus presentation that we provided to this committee earlier. I'll have to admit, I had no idea what white bagging was before this topic was listed, but we do have some, Corey Cooper, our pharmacy, Medicaid pharmacist. She's an expert, and she provided a lot of really good information. She's my lifeline for this brief. So if there are any questions, I will be happy to throw her in front of the bus. So on slide 21, just kind of talking about what white and brown bagging are generally. Really, they are kind of very specific situations where you have drugs being administered in a physician's office. And so those are typically cases where you really need a really precise dosage or something really tailored to the patient, an infusion where it requires an IV. So chemotherapy is kind of one of those instances. What happens is basically with white bagging or brown bagging, in the case of brown bagging, the insurance company will basically contract with a specialty pharmacy and ship those drugs directly to the patient, and the patient will bring those drugs to the office for administration. And then white bagging is where the drugs are shipped directly from that payer contracted pharmacy directly to the healthcare setting. So in both settings, basically you're sort of bypassing a local pharmacy and shipping the drugs from a payer contracted specialty pharmacy to that physician's office. Why do they do this? Along with prior authorization, there's kind of a theme here. One of the main objectives here, and this is slide 23, the primary reason is to control utilization and cost. In some cases, they can contract with one vendor, one specialty pharmacy, and get a lot of potentially some discounts because they're contracting at scale and with a lot of volume for that one pharmacy, as opposed to trying to buy those drugs, very unique, often very unique drugs on a onesie twosie basis with a local pharmacy. So there may be some cost savings on the payer side with that purchasing power, but there's also a utilization reason. Basically the idea is that, and it's one of the reasons why Medicaid does practice white bagging in one instance, and you can see it on slide 24. It's really sort of appropriate medical dosing or using the drug appropriately. So since 2010, we have required white bagging for one drug, which is a prophylaxis for RSV in high-risk kids. And the idea was really to align the dose with appropriate AAP guidelines because the dose is closely tied to the weight of the kid upon administration. And really, so the idea was to try to save money on the utilization side by reducing waste. And so that's really the only drug we do white bagging with, and there was a very specific reason for it. And you can see that in 2010, we had a high of 967 prescriptions, and that dropped to 587 2 years later. So we've saved approximately $650,000 each year by implementing this policy. Of course, there are concerns. It's done primarily for those cost containment reasons, but both brown and white bagging do come with concerns. So slide 25, there really are many more concerns from a chain of custody perspective with brown bagging because you're sending the drugs directly to the patient, and there's all kinds of issues with cold chain, with the patient losing the drugs, and potential liability that might cause on the administration side of things. So white bagging is a little bit less risky practice, but there still are concerns. Obviously, there's because the payer is kind of micromanaging in some way the dosage and administration. The payer may not be aware of the exact weight or the exact lab measurements in a timely fashion by the time they ship the drug, so there may be sort of mismatches. There may be more timely information available at the doctor's office that might affect the dose. And so the drug might not be shipped on time, so there's possibility for waste there. And of course, it can skip all the controls that the physician's office might have on their own internal pharmacy system, like checking for drug interactions or other kind of issues there. So there obviously are pros and cons to this practice. Hopefully this presentation kind of provided just a very high level overview of those pros and cons, and as well as providing you some information on one specific case where Wyoming Medicaid does it and why we do it. So with that, I'm happy to take any questions or field those questions to Ms. Cooper.
And you'd like to continue to do it, I suspect, in that case. All right, questions for Franz? Dr. Cooper, welcome. We can see you, maybe you can't see us, but floor is yours if you have anything to add.
Mr. Chairman, members of the committee, Corey Cooper, Pharmacy Program Manager for Wyoming Medicaid. And I believe Franz did an excellent job, so I'll just be here for questions if needed, but I don't have anything to add to the overview he's given.
Okay, Mr. Grossman, nothing to add as well? Any questions to the Department of Health? Not seeing any. Commissioner Rude, anything while you're at the table?
Jeff Root, Commissioner of Insurance. No, we really don't have anything to add. We, like the Department of Health, really weren't even aware of these terms and their utilization until last year when there was some legislation that went out across the country. I know it's only been passed in a few states, but we have no dealings with, we haven't talked with insurers about it. We haven't had any complaints from consumers about it. We haven't had any interaction concerning it, so.
Easy enough. Questions, anyone? Not seeing any. Thank you all for the presentation. I know we have some other people here to testify. Not sure who wants to come up next. Mr. Hayes, welcome.
Good afternoon, Mr. Chairman, members of the committee. My name is Ralph Hayes. I'm the manager of the Employees and Officials Group Insurance Program. I wanted to speak briefly upon the white bagging and how it does work for the Employees and Officials Group Insurance Program. Now, Cygnus Healthcare team does arrange white bagging where appropriate, because it's not appropriate in every situation, to avoid really the astronomical markup that facilities utilize on medication infusions they administer, which ultimately lowers the cost for the plan and ultimately the premiums and employer contributions for the participants and the participating entities. With multiple facilities in Wyoming, the rough markups are anywhere from 400% to 700% of average sales price. So it's significant. And just to give you a comparison, Medicare prices drugs at 106 of average sales price. Now I'm going to give you an example. This actually happened this month, where we arranged a white bagging situation. It's for Rituxan, which is used to treat non-Hodgkin lymphoma and chronic lymphomic leukemia, et cetera. Also used to treat rheumatoid arthritis and other things such as lupus. Now that particular specialty pharmacy was $18,715 for a single infusion. If the ranges are correct, which I believe they are, that same infusion, just for the drug alone, not the administration, would have ranged between $74,000 and $131,000. So you can see that where appropriate, white bagging does provide significant savings to our program and ultimately lowers the premium cost. So that's a savings of between $56,000 and $112,000 for one infusion.
So just to make sure I understand your testimony, they're shipping directly to patient then and going around the pharmacy in this case?
Mr. Chairman, members of the committee, how this works is there's no break in command. The patient does not get these medications. It's shipped directly to the facility or the office where this infusion is being done. So, you know, that chain of custody is unbroken.
And white bagging. Okay, questions for EGI, Representative Clouston.
Thank you, Mr. Chairman. Thank you for being here, sir. As far as chain of custody, some of these medications are temperature sensitive. So the bag, the medication gets shipped to the hospital or the facility and it's administered. But if it wasn't handled properly, who's legally responsible?
Mr. Chairman, members of the committee, I cannot answer that question.
Okay. So my second question is, follow-up? Yes. Somebody from Wyoming goes to get their cancer treatment in Denver, drives 400 miles. Medicine's coming from Cigna Express Scripts. Medicine doesn't show up. So someone's taken off work for 2 days, told to come back the following week for the cancer treatments because there was a transportation issue. How does Cigna handle that with these patients?
If you know.
Mr. Chairman, members of the committee, I can't speak to that.
Any more? Nope. Representative Hornock.
Thank you, Mr. Chairman. So what's the issue with any of this? Are we talking about a chain of custody issue?
Go ahead,
Mr. Chairman, members of the committee, from our perspective, we believe white bagging is an important cost containment feature for our program because it ultimately provides significant savings in cases where it can be applied. Now, mind you, there's some of these medications that white bagging makes absolutely no sense. And for the timing of the treatments, but where it is appropriate, again, significant savings in this one case, anywhere from $56,000 to $112,000 for one infusion for one patient, the savings can be quite impressive.
And Representative Hornock, we probably should have started with different people testifying first to discuss their concerns, what the issue is. So you probably haven't heard of why this is before us and what the concerns are. We're starting kind of backwards, but other questions for Ralph? Senator Hutchins.
Thank you, Representative O'Hearn. Mr. Hayes, you've mentioned several times that this brings a considerable cost savings to your insurance plan. Can you describe to us how this is, that we know that we're really getting the best cost?
Sure.
Mr. Chairman, members of the committee, we do see claims. So we do understand what the markups are on these prescription medications. We can look them up to see what the specialty pharmacies actually charge. And in this particular case, I had an exact sample that came from right this month. So we can absolutely check and double check what would be charged. And often it's, they were having it done in a facility and the Cigna case manager is trying to move it to the white bagging to provide that cost savings for the plan. So yes, we can see the savings.
Yes, thank you, Mr. Chair. You can see the savings, and you mentioned just one incident, and I'm just assuming that out of the thousands upon thousands of drugs being administered each day, each week, each month, this is just one. Do you have any other examples you can share with us?
Mr.
Right,
Chairman,
Chris.
members of the committee, I did not bring other examples. I just found out about this committee meeting Wednesday. So I reached out, got a specific sample from my assistant manager who is participating in this particular prescription, getting that member filled through the Cigna case management. So all I'm prepared to do today is speak to this one. But it is a good example of the type of savings that are available, again, because the considerable markup that is in place at facilities who do infusions.
Thank you.
Representative Clausen, question?
Thank you, Mr. Chair. Just one more follow-up question. What happens if a patient goes for their chemotherapy treatments? The medicine's been shipped, it's on site, and all of a sudden their labs have changed. They need a different amount of medication for that treatment. Is the facility then allowed to mix their own and charge the price, and the stuff sent from Express Scripts is thrown away? What's the process when that situation happens?
Mr.
If you
Chairman,
know, Mr.
unfortunately,
Case.
I do not know the answer to that.
But I bet someone in the back of the room knows the answer to that one, and we're going to talk about it. Other questions for EJ? Not seeing any. Thank you very much, Mr. Hayes. Oh, you do have another one. Go ahead, Senator Hutchins.
This is maybe an incidental one as well. When you sit down with the insurance companies to create a good plan for the state, do you do this on your own or do you have people with you? Again, how are we as a state knowing that we're getting the best bang for our bucks with these discounts? How do you come up with that decision?
Mr. Hayes.
Mr. Chairman, members of the committee, we do have an advisory panel who works with us. I do report to my manager, the director of ANI, and of course, the governor's office. So when we go out for, we put our programs out for an RFP generally once every 5 years. So it is a competitive bid process. We utilize consultants who are pretty much experts at what questions to ask and dissecting what the answers are and making modeling cost comparisons based upon the information submitted. So it is not a decision that I make on my own. This is a group decision. We do involve our advisory panel members, and we do involve upper management.
Thank you.
Thank you much, Mr. Hayes. Not seeing any more. Hospital Association, you want to come up next? And you're welcome to bring Mr. Sylvie with you. Is he part of your group? Or we have 4 chairs, if you all want to come forward. I think just from the hospital setting, you're kind of all affiliated, so. I think we're starting with Mr. Hannis. Go ahead.
Okay, sure. Mr. Chairman, members of the committee, Josh Hannis with the Wyoming Hospital Association. I'll be very brief. Some of the concerns that we have already been touched on, and then our experts from the hospital setting can talk to you about the details and how that works, and I think answer a lot of the questions this committee has about process and when challenges arise. But just to sort of reiterate, our 3 issues with white bagging as a process really center around a couple things. One is, as was already mentioned, our delays in patient care. So cancer patient comes in, they receive labs that day, as Representative Clausen talked about, and their dosage changes, right? So either the facility can go into their own stock and not be paid for that, or they delay care. And we see that as a patient safety issue and interference with a course of treatment for their disease or condition. The other has to do with the line of sight into the chain of custody, right? So again, as was already brought up, some medications are temperature controlled. They arrive at the facility. There's no way to know if those were handled appropriately. And there becomes concern then about delivering those medications to the patient as a patient safety issue. And then the third, again, just at a very high level, has to do with the administrative burden that's placed on facilities. We are regulated very heavily in how we manage and monitor our prescription inventories. And this requires us to keep now multiple inventories. So you have your hospital, in our case, inventory medications, which is managed and regulated. And then you have individual inventories for every patient that you might see and say on the infusion side. So there's this additional burden that these gentlemen can talk about in greater detail, but want to put those concerns out for the committee.
Mr. Boley?
Mr. Chairman, committee members, Eric Bullock, with Wyoming Hospital Association, and I'll just add a couple of other things. As we look at white bagging and the practice of white bagging, and now there's clear bagging that I just barely heard about, brown bagging. We're specifically focused on white bagging at this point, though. I'm sure we may end up talking about clear bagging in the future, who knows? And someone brought up black bagging earlier today, which has nothing to do with pharmaceuticals. So one of the issues here is we take a look at the rural nature of our state. How long was I-80 closed this winter during the whole entire legislative session? So if we're counting on these contract pharmacies to fill and get these specialty drugs where they need to be in a timely manner and allow treatment of these patients, there are some real concerns with that. The thing that I would say is we've brought forth legislation was passed in Louisiana just this last year, was passed unanimously. Everyone in the entire state legislature voted in favor of it. And it does not preclude white bagging, but what it does do is it builds in protections for our patients and for our providers. And I think that that's an important thing. We actually have talked with our hospitals. We've got some of our small rural hospitals that just don't have the money or the capacity to carry some of these specialty drugs internally. And so white bagging actually benefits them to a degree, but there need to be safeties put in place. And when we look at our providers, who are the ones actually providing the treatment, they're the ones that are diagnosing, they're the ones that are examining and watching the treatment go on. There are no safety measures in place right now if the prescription changes, if the doses change. And so there are some big questions that Mr. Hayes couldn't answer. And I'm not particularly sure I know the answer. If we have the white bagging drugs in our facility and we have to change dose or we have to go a different route, what happens to those white bagging lists? So I think our insurance companies, PBMs, can probably answer that for us. But the physician should have the ability to change and treat the patient appropriately in the right setting. I think Representative Closton brought up a really good example, and this is kind of what happened in Louisiana. There was a legislator there. She was undergoing cancer treatment and was caught up in this white bagging issue where the drugs didn't arrive on time. But I think it's a great example to drive 400 miles waiting for drugs that are supposed to be delivered and they're not there. And then what do we do? And the facility itself is just kind of sitting there twiddling its thumbs because they're not allowed to use the pharmaceuticals that they have readily available to treat that patient. So I think we've kind of found a sweet spot here where we're not precluding white bagging, but where we're putting safety measures in place for the patient. We're allowing prescriptions to be filled that if they're prescriptions that are held by the hospital or by the clinic or whoever it is delivering that care, there are provisions within the Louisiana legislation that would make sure that those are paid for, but not at a huge markup, as Mr. Hayes indicated. And so I think we've tried to present a really reasonable approach to this to make sure that our patients and our providers are cared for and are protected through this practice. With that, I'll turn it over to our experts here.
All right, Mr. Sylvie, just state your name and who you're with for the record and share with us what we need to know.
Hi, my name is Les Sylvie. I've been a pharmacist for Cheyenne Regional Medical Center for 29 years. But also on top of that, I also have a wife that had cancer and it's chronic and a lot of care condition as well. So I'd like to speak not only as from the professional side representing Cheyenne Regional Medical Center, but also from a patient empathetic point of view. Delay of care is something that's been consistently spoke about. And it's only 3 little words, but it is very disruptive in patients' lives. You've rearranged your lives for a treatment that may or may not be there for several, or have problems along the way for several reasons. I'd like to go through every one of these situations have been confirmed that it occurred and affected multiple patients. I'd like to go through them, how it affects us and how it affects our patients. Some of these medications, when they come to us, they come with an invoice paper with a patient's name on it instead of a proper label. That's a problem when you're trying to process this on outside your normal way of processing orders coming in. Because if the paper gets separated from the medication, we don't ever have the legal title to those medications. They are not ours, they are the patient's. And then when that paper gets separated, it creates confusion and a lot of paperwork to correlate it and make sure that that patient-specific medication gets to that very specific patient. No, we cannot use our own medications for those patients. We will not be paid. And so they have to be kept as a separate inventory, meaning if you have 20 patients and your own, you're managing 21 different inventories. Medication can also be sent with the patient name on the box and can occasionally be delivered to areas or to personnel who are not involved in that patient's care. That's a problem for several reasons, but one of them is it's a HIPAA violation. That patient has medications, their name on it, their treatment, which you can easily tie to a treatment, and it now has been given into the hands of somebody who has no right to have that information about that patient. Medications are delivered to the incorrect location. We have to search for the medication. These are often hazardous medications placed in inappropriate areas that increase exposure risks to others and often also can result in patient care delays. It can be delivered and sit on the dock. It can be delivered to the lab. It can be delivered to the wrong part, to radiation oncology. It can be delivered to several different medical desks. And we have had to search for these medications, and they've been opened. And not only does it create a delay trying to find these medications, but it also increases the risk of these chemotherapeutic drugs of exposure to people that are not trained to properly handle them. Refrigerated items are delivered after hours, and the cold chain delivery can be broken. The medication has to be wasted and reordered, of course, resulting in another delay of care for a patient. This happens. We also have to remember with the delivery chain, it's very difficult for us to assure that that medication has stayed at the proper temperature and have been treated properly when we receive things outside of our normal cold chain delivery. We basically have now just created chemotherapeutic waste that has to be wasted, and it's expensive to waste, and also the patient delay of care. Medication tracking, and I kind of touched on this before, of white bag medication is a manual and labor-intensive process. Once again, we have to keep track of every single individual patient. And since it's all outside of your normal tracking processes, it's very difficult, and you have to store them separate and differently. The white bagging process often requires a practitioner to utilize a home healthcare infusion company. Many of these medications require immediate infusion. Definition of that is less than 1 hour from the time that it's prepared. The logistics make this difficult, and I often wonder how are they actually achieving this if they're doing it appropriately and properly. The other question that we have is a lot of these medications have a high risk of an adverse drug reaction. Are those medications available? The practitioner isn't there to immediately manage the treatment of those adverse drug reactions. And so I don't know how we are mitigating these serious risks which do occur on a regular basis. I think Tim will be better to talk about more of the regulatory aspects of it. But what I wanted to point out is white bagging severely affects us, as well as severely affects our patient in an adverse way.
Okay, we'll just go over and then we'll throw questions at all four of you. Tim.
Mr. Chairman, members of the committee, my name is Tim Steffen. I'm the Director of Pharmacy Services at Cheyenne Regional, and I'll talk to you a little bit about some of the regulatory issues that I deal with this. So those white bag medications are basically a contract between the payer and the patient. So we don't own those drugs, as Mr. Sylvia said. So bringing them into our organization, it bypasses all of our electronic tracking pieces. So the biggest issue is I don't know if you've heard the Drug Supply Chain Security Act. And that's where pharmacies are required to electronically track from manufacturer to patient the drugs where they're in contact with. But when it's a patient-specific medication coming from these pharmacies, it's not required to send us that tracking information. So those drugs, if they're not used, we can't use them. We've been asked that before. Can you use one of yours and just put what comes in your stock? We can't do that. It's basically waste after that. And that's probably why they will not receive them back, because we can't submit tracking information. We don't have it. We never got, the chain was broken at them. The other thing we go into is our inventory system. Everything is done, ordered electronically to our wholesalers, and we track that from the moment they ship it to when it gets to us, and it's usually within 24 hours of coming to us. And when it comes into our system, where it's electronically built and tracked in our system, these white bag drugs are not built into our system. So we can't, it bypasses all of our barcode scanning safety features and a lot of our clinical programs. So and what they didn't let you know too is with preparing those drugs, the white bag pharmacy doesn't have the responsibility of bringing that drug in. We have to have the staff to mix it, handle that waste, make sure our staff is properly trained, and then, of course, the disposal of it once it's done. And we don't see a penny for that either. So we're using all of our resources for that and with nothing to show for it. So basically, we're just taking on all the liability and risk for those drugs.
So, and if there's any question with the chain of custody or refrigeration, I assume in all cases, it's better to be safe than sorry and you don't administer those drugs. How often, I mean, out of 100 white bag cases, do you have an issue like that come up?
Mr. Chairman, probably just about every one of them. That's the pharmacist's responsibility, is to take a look at that drug. When it comes in, depending on how long it's been since we received it from the shipper, you can usually tell, especially with the winters, how cold it's been or the heat of the day. Those UPS trucks, a lot of times they may not be temperature controlled. So you may get something in frozen or super hot, and they're stable in certain narrow temperature ranges. So it's a pharmacist's judgment to look at that and determine if it's been stored within the temperature range or handled properly.
Okay, questions, committee? Senator Hutchins. Go ahead, Mr. Stefan. Whoever touches the mic first gets it. Go ahead.
Mr. Chairman, Senator Hutchins. No, we're not considered a specialty pharmacy.
Mr. Boley.
Mr. Chairman, Senator Hutchins, good questions. Back to the first question, we aren't specialty pharmacies, but we can order specialty pharmaceuticals, specialty medicine. As far as the protections, I think it's pretty clear in the draft legislation that we sent over. The protections we want is that if we don't get the drugs in time, or if we have concerns about the chain of custody and them being safe, we can still go ahead and treat the patient with our own, and then we have a guarantee that we'll receive payment for administering the drugs and also for the drugs themselves.
Another thing you mentioned, and this is kind of new to me, if you don't mind, a drug comes in, white bag, and dosage is changed. What is it you want to be able to do when that dosage is changed? You got that drug that's been sent to you, according to Mr. Hayes, it could be an $18,000 drug or whatever. What are you supposed to do at that point?
You can jump into, Mr. Chairman, Senator Hutchins, that's another great question. And we don't know the answer to what we're supposed to do with them when they get there, but what we want to be able to do is if the dosage needs to change and we need to adjust that, it's not what we want to do, it's what our providers, those that are administering the pharmaceuticals, the drugs, want to be able to do, is to take care of their patient and utilize whatever means they have to make sure that they can continue that treatment.
So let's just say, I don't know drugs. Drug A is sent, and the dose is 4 pills an hour. But the doctor says, no, I only want you to take 2. So, or once you take 5 now, what do you do? Because you have 4, I mean, you can split it, but what is it that you on your side, now that the dosage has changed, where can you find that specialty drug in your hospital to fix what the doctor is now prescribed?
Go ahead, Mr. Bully.
Mr. Chairman, Senator Hutchins, I have some ideas, but I actually think it might be better to let our experts here talk about it. I think one of the things we're talking about with these specialty drugs, though, is that they need to be compounded, they need to be mixed. And so it's not as easy as cutting a pill in half or giving 3 pills instead of 5. We actually have to adjust the drug itself, how it's mixed and how it's administered. And that's a much more complicated issue than just cutting a pill in half and changing the dosage. You guys could probably answer that better.
So Mr. Sylvie or Mr. Tim want to jump in?
Sure, and that'll be 5th question. Go ahead, Mr. Stefan, if you'd like.
Mr. Chairman, Senator Hutchins. What typically is, just like was mentioned, is most of these are IV mixtures that cannot be split like that. It'd be, if the dose is changed or anything like that, either we would either have to supplement that, and we can usually get drugs within 24 hours, whereas coming from one of these white bagging pharmacies, there's not a true 24-hour overnight delivery to Cheyenne, Wyoming. It gets to Denver in 24 hours, and then it's trucked up here the next day. So it's usually a couple days later, so we can usually get it a little faster for them if we need to order it.
So therefore, the delay in care. So, one of the things see this legislation, but what would be your idea of your ideal idea on how we can best help?
Mr.
I'd have
Sylvie.
to say sorry. Mr. Chairman and Senator Hutchins, I think the cost savings in which they're referring to, what is charged and what is paid is 2 extremely different figures. If you on average get paid 37 cents on the dollar, and I charge $100 and I get paid 37, that's really not a savings for anybody. The drug costs a certain amount. There's a paper amount on that, but you're only going to get paid so much. Doesn't matter what you charge. We work very hard to receive medications at an appropriate price through working with a buying group. We also try to make sure that the drugs that we choose to utilize are the quality, and we can create the best patient safe and effective and excellent patient care that we can. I think that if there is an institution that needs to utilize white bagging, and that is their choice, or an institution where it is takes away from the patient care, I think that the practitioners or the institutions should have a choice whether white bagging would be utilized for patient care.
Do you, go ahead, Senator Hutchins.
Thank you so much. Mr. Sylvie, I love the patient choice. So if it was a patient's choice, then they would brown bag instead of, I think it's brown bag, instead of white bag? Would that be the choice?
We can't really allow brown bagging because it, if there's a chain supply break and the medications now go into hands that can't utilize it now, and we could have to consider it adulterated at that point, and we can't use it. So the second part of that question, I'm sorry, could you repeat that?
I'm gonna change it. Like I say, the patient choice, and it wasn't so much patient, it was the pharmacy choice. Who's receiving that drug? You want them to have a choice whether it's white bagged or what?
Or
Because
that,
it's like you're getting the medication in that I need and it's specialty. How are you gonna have that if it's not white bagged to you?
through
Go
our
ahead,
normal
Mr.
supply.
Sully.
Do you
Oh,
know?
you're fine. Go ahead, Mr. Sully.
And I hope this is helpful to everybody because I want to understand it.
Chair
So thank you.
and Senator Hutchings, through our normal supply chain.
Okay,
It's very simple. We just put in an order and it shows up the next day.
gotcha, gotcha. Thank you.
So with the question, if something's adulterated or you don't feel comfortable with it, you don't administer your own, you order it and tell the patient to come back tomorrow? What happens when it's a serious event where they need that medication? I mean, does the hospital just eat the cost? And what are your options now, I guess, is the overall question I'm asking.
Mr. Chairman, the options right now, we don't want to give it to the patient because it's unsafe to give them, and or it won't be effective for them. So either we will utilize, we will have to order it again and get that drug back in within 24 hours. Or if we have it in stock, we can utilize what we have in stock for the patients that we're providing the drug for.
But then you might not get reimbursed, or you would have a payment fight with insurance to get reimbursed for that if you take it from stock.
Mr. Chairman, yes, we probably would not get reimbursed for that. If it come in and was not usable, we would segregate the drug and we would contact that white bagging pharmacy to say, here's what we have, and we need more of the drug. And yes, the patient would have to come back unless it's really that critical and the provider wanted us to provide that drug immediately, then we wouldn't probably get paid for it.
And then, so the specialty drugs, before I get to Representative Penn, when you talk about you need to mix them or create them, is this a 5-minute process, a 30-minute process for most drugs? I mean, what's the level of involvement that you take between getting the shipment and administering it for the average drug we're talking here?
Mr. Chairman, by the time we receive it, a lot of it is around storage, putting it into refrigeration and making sure that we know where the drug is located. Once we get that physician's order and the patient's appointment comes up, the order is released. It varies depending on the drug and how the drug goes into solution, if it's a powder or what have you. So it could be 10 minutes, it could be 30 minutes, it could be an hour. It just depends on how long, or the drug itself, it's drug specific. Also, the various, some of the drugs produce hazardous vapors, so they require what they call they have a specialty syringes and prep products that the staff have to use. Some of those are take a little more time to put together and utilize to mix these drugs than just a standard needle and syringe.
Representative Penn.
Thank you, Mr. Chairman. Okay, I have a couple of questions, but they kind of all come around the same thing, what you'd mentioned before. So one, you'd mentioned if you had what you would like to do, if you had a drug that maybe the dose ended up changing, you needed to adjust, you said you would then potentially take from your own stock or order your own drugs that you can get quicker. Why are we not doing it that way now? Tell me the difference between, is it that the insurance company will only pay for that drug if it comes, if it comes from this particular pharmacy, so you're not gonna get reimbursed for that extra, say you need, you were at 400 milligrams, now you need 450, you're gonna take 50 from your own stock, you're not gonna get reimbursed for that 50, is that what you're saying?
Mr. Steffen, go ahead.
Mr. Chairman, Representative Penn, yes, we will not get paid for that.
Okay. Mr. Hannes, do you want to jump in on that, or so far so good?
Okay, and
Go ahead.
if I may follow up. So currently, if you have a drug that you get that you deem unusable for temperature purposes or whatever, or the dose has changed, what right now happens to that? Do you get paid for that drug? Or does that drug get paid for, or who ends up eating that cost?
Mr. Steffen.
Mr. Chairman, Representative Penn, You know, I don't know who pays for that drug. The drug, we just take the drug that's not usable or that maybe the patient doesn't need it anymore. Maybe the drug's changed. So we had a refrigerator just about full of those type of drugs that we have to end up wasting. Putting in the
But
hazardous
you're
waste.
currently not getting charged for those?
No, patients, usually, it's a prescription that the patient insurance is already paid for. And so that's why it should be labeled when it comes to us, it should be already paid for. So we can't charge for that drug.
And do we know if the patients are getting charged for, like, that dose wasn't usable, we're gonna have to send another one? Is the patient getting charged for this, or it's just the fact that the patient has been put out because they were planning on this treatment on this day and it didn't happen?
Mr. Steffen, if you know.
Does and anyone can answer that?
Representative, no, don't know that answer. How they handle that, the insurance company or the pharmacy handles that, that's not information we're given.
Okay.
One more?
Oh,
Yep.
I have one question. Did you have, it looks like he might have had a response.
Mr. Boley.
Mr. Chairman, Representative Penn, I think the answer to this is the insurance company pays for what comes to us. What's done with those doses that are in question and aren't used, I guess they're returned, they're basically wasted. I think the more important part is we have a patient in our facility that is expecting treatment at that time, and we try to fill that need. And if we have supply to be able to provide that, or we need to get it in as quickly as we can, we do take care of the patient, then there's no payment. And so I think in answer to Senator Hutchins' question, we would like to have coverage as we take care of these patients. And we want it to be reasonable. I mean, we understand that there is some cost savings involved with the PBMs or the insurance companies filling these specialty drug prescriptions. But the most important part here is the patient experience and getting the patient the need is the care as quickly as possible and in the right setting with the right doses.
Okay. Chairman, can I just have one more
You can have
question?
one more, and then Representative Hornock. Go ahead.
Thank you. Mr. Boley, you had mentioned, so if we have to change the dose, and if that was allowable, it takes a compounding pharmacist, which is a separate certification or license, if I know correctly. I know all pharmacists aren't going to have that availability. So in the hospital setting right now, I don't know if you guys are compounding pharmacists, or I guess we just need to make sure that if we do decide to go ahead with legislation, we need to make sure that we have something in there that says that we have the appropriate licensing, or whatever, the credentialing, so that is happening as it needs to happen, because not everything happens in a hospital. My clinic does a lot of infusions. They don't do chemotherapies and things, but similar type of things, maybe not with these types of drugs, and we don't have pharmacists. And so I don't know if you have any comments.
Thoughts, Mr. Boley? Make sure your mic's on.
Agreed, yeah.
And so is this primarily an issue that deals with hospitals or, clinics? I know the reason for the bill is coming from the Hospital Association, that's where the main issues are. But for most of these specialty drugs, they are administered at a hospital or a clinic. But we also talked a little bit about home infusion, like there are some home health people that would travel and administer these, but are those mostly run out of their local hospital, the home health, or are there private independent home health operators who are utilizing specialty drugs as well?
Mr. Chairman, it's another great question. And I think we brought this forward, but we think it's broader, it's more global. There are a lot of home health agencies that have they're standalone and they take care of that. This affects clinics, it affects hospitals. There's a lot of different settings where this takes place. And I really think this is a patient safety issue and a patient treatment issue.
You're not trying to stop the practice, you're just trying to make sure there are some patient safety mechanisms, and an ancillary benefit would be the correct payment and nobody having to waste drugs that don't need to be wasted if you could ensure that they get labeled and are delivered appropriately and there's some extra care to ensure that we don't administer drugs that would harm
Chairman,
someone.
That's great.
Okay. Other questions this side of the room? Representative Hornock, you had one, and then I'll go back to Senator Hutchins.
Thank you, Mr. Chairman. I've got 10 questions too. But I won't ask them all. So is this more of a problem? Are we talking about a problem with specialty drugs, or does this happen across the board with any type of medication? I can understand that the issue with specialty drugs and temperature-controlled chain of custody issues, but is white bagging a possibility with all drugs across the board? And then what about self-insured people or underinsured people? What happens in that realm with what we're talking about?
Mr. Bully?
Mr. Chairman, I'll take a stab at it. We are talking mainly about specialty drugs. So white bagging, it's kind of the purview of white bagging. Brown bagging is a little bit different. It's where prescriptions are filled and shipped directly to the patient, and then the patient brings those into our facilities or to their caregiver, and they're expected to be administered by the caregiver from out of the brown bagging prescription. And I don't think that that's nearly to the degree of what white bagging is as far as specialty meds are concerned. What was the second part of your question?
The underinsured or uninsured aspect.
So, Mr. Chairman, Representative Hornick, I mean, again, it's their insurance plan that's filling or basically sending the white bag. So we're going to take care of the patient one way or the other. We've already accepted their care. It's just where the drugs and the chain of command to make sure those drugs are properly stored, properly cared for, and properly administered falls on us.
Thanks. This is number 10. So explain the chain of custody. In my opinion, when a patient, is there something on the federal level that I don't know about with the chain of custody issue on this? I would say that when the patient themselves receives the drugs, that's part of the chain of custody. Or am I missing something on that?
Mr. Hannes?
Mr. Chairman, Representative Hornock, as they talked about earlier, we are required by rules to have insight into the chain of custody all the way from the manufacturer to the delivery to the patient. We don't have that level of insight when the ordering and delivery of that medication happens outside of our system. So if we don't have it from creation to the time it goes into the patient, those breaks in there create the patient safety issues that we're talking about.
Senator Hutchins, you have another question? Okay. Mr. Steffen?
Mr. Chairman, Senator Hutchins. The code I was talking about is the NDC number, the barcode that's on the vials that we use. Those are standard. Those are standard across that drug, no matter where it's at.
Okay.
What we're tracking is the lot number and expiration date as well. That way we can account for where that drug, if there's a recall for that drug's been recalled for whatever reason, we know who got it. And that way we can make sure that we can contact them if we need to.
Gotcha. Really quickly, the follow-up was, it seems to me, when you say that you have a refrigerator full of unused drugs, and Mr. Hayes says that these drugs can cost as much as $18,000, there's no savings to the insurance company at all. Just a guess. Thank you.
Since you're not the insurance companies, probably don't need to answer that one, but.
I got the answer. Thank you.
All right, other questions of the Hospital Association? Any closing comments from, do you have another question, Representative Klauston?
So gentlemen, what I'm hearing here is, our concerns are utmost the patient safety issues, right? We also have medical waste, but we also have cost-saving issues here. Do you feel like this draft legislation covers all three of those areas? I mean, will What are your thoughts on the way this is written to address those three?
Thoughts? They're deep in thought. Thoughts you want to share? Mr. Bully?
Well, Mr. Chairman, Representative Costin, I don't think we'd have brought the draft legislation forward if we didn't think it addressed most of our concerns. Obviously, as you look at the reimbursement methodology in there, I think it tries to hit the sweet spot where we're not talking about the astronomical markups that Mr. Hayes talked about, but where we are making sure that we're getting our costs covered. I think that it builds the safeguards in place for us to be able to treat the patients as needed when necessary. And I think it's a really good starting place. Yeah.
Okay. Other questions? Good. All right. Thank you much for being here.
Yeah.
Other people here to testify on white bagging? Ms. Rowe, you guys can come up together. It's a big table. Working on traffic patterns here. Welcome, Ms. Bush, Ms. Roday, Ms. Mack. We're going to fill all 4 seats here in just a second. But since you were first, Sheila, go ahead.
Mr. Chairman, members of the committee, Sheila Bush with the Medical Society. I will be very brief. I asked a physician about these issues when they came up, and they gave me an analogy that I thought was really helpful. And so I was just going to share it with you, kind of put this together. Currently, the pharmaceutical administration piece looks a little as though if you were to go to a restaurant, that restaurant buys their own food, they bring it into the kitchen, their chefs prepare it and bring it to you at the table, depending on what you order. White bagging would look like going to the restaurant, but each individual patron of the restaurant has contacted a vendor, and the vendor has sent the food to the kitchen to be prepared, but the kitchen doesn't know where the food came from or the vendors. And brown bagging would be all of the patrons of the restaurant bringing their own ingredients in a brown bag to the restaurant and then giving it to the kitchen to prepare. So it's a little silly, but I also thought it was really helpful. It sort of made everything a little clearer for me. For the Medical Society, this issue is most prominent in oncology, as you've heard. And it's my understanding, and this is where my lack of expertise in medicine will be evident. But with oncology, my dad has cancer, and so I know from the experience with him, he does labs the day before or sometimes the morning of his treatment. And then the hospital where he's receiving care mixes that infusion for him that day based on the way his labs looked that morning. That's really important for him and his treatment and timeliness. He gets infusions every week. And so in this case, the ability for the hospital to be able to do that and to change those mixtures and those cocktails depending on what they see in the labs is really critical to his care. And so the process and this practice of white bagging really does interfere with patient care. It creates some significant delays in that treatment. And I think we have questions at the Medical Society about, as this practice potentially becomes more prominent, what it means for liability for our physicians, and what that really looks like. And so with that, like I said, I would be brief, but.
Questions for the doctors? Seeing none at this time, Ms. Roday?
Good afternoon, everyone. Again, my name is Heather Roday, and I represent Blue Cross Blue Shield of Wyoming. As a reminder, healthcare in Wyoming is paid for by our neighbors who are Wyoming citizens and business owners. Our members expect us to be good stewards of their money, and as such, we want safe, timely, and cost-effective treatments for them. When a member must have infusions for their treatment, the medicine can be administered in the physician's office, in specialty medical clinics, an infusion center, by home health staff, and in hospitals. And we've talked a little bit about that so far. The type of infusion services varies from high need for those patients who are starting a new treatment where reactions are unknown and emergency treatment might be needed, to low need where those patients with longstanding experience with the drug and no reactions are expected can be treated in a less intense setting. The most expensive drugs are injectables and infusion drugs provided by some hospitals and hospital-owned infusion centers. This cost is not based solely on the high prices of the drugs, but also because some of the hospitals are marking up these drugs. New state and federal price transparency laws show that some hospitals are marking up drugs at excessive amounts, on average of 200 and up to 634% for cancer drugs. For example, Neulasta, we were just talking about cancer drugs, is a post-chemotherapy drug used to help reduce the chance of infection in patients. The drug is recommended after every chemotherapy cycle by the American Society of Clinical Oncology. Average markups are 364%, according to Alliance Bernstein analysis, and also based on hospital price transparency. An average wholesale price of $6,400 means that some hospitals on average are charging over $23,000 with a markup of over $16,000. By comparison, Medicare will not pay more than 6% markup for profit margin. Blue Cross Blue Shield of Wyoming has identified vast differences in the way that our infusion services are billed by Wyoming providers. So services billed in physician offices, specialty and infusion clinics tend to be the least expensive. Services billed in the smaller hospitals are a little bit more expensive, and services billed in some of the largest hospitals tend to be the most expensive and by a wide margin. So we have a hospital in Wyoming that charged our insurance company $1.9 million for a drug for one member's annual therapy that would normally cost between $500,000 and $600,000. So let's talk about that. $500,000 to $600,000 for a course of treatment over a year is what it cost. And the charges that we received were $1.9 million over the year. Every day we see larger volumes of patients with drugs costing $10,000, $25,000, even $100,000, which have significant markups and come out of consumers' pockets and the insurance companies. So health plans are responding to these excessive markups by bringing in the same drug from lower cost pharmacies, and it saves patients and the plans a significant amount of money. An independent report from 2019 submitted to the Massachusetts legislature by their state's health policy commission found that bringing in lower cost drugs reduced the price of drugs for patients by 38% on average. So Wyoming patients end up paying for these markups through out-of-pocket costs that are higher and higher premiums, and a white bagging prohibition would remove tools that insurers use to reduce the high cost of administering infusion drugs. When the treatment can be safely performed at a lower cost infusion site, prescribing prescriptions are unaware that cost differences by site exist, and when it is clinically appropriate, they and members are willing to receive the care at that lower cost facility. These facilities are in Wyoming and offer comparable services at a lower cost. Blue Cross Blue Shield of Wyoming is happy to support them as a way to reduce healthcare costs for the plan and our self-insured clients. The proposed legislation that you have has us concerned, as it has been couched as a white bagging bill, but it actually goes beyond white bagging and reaches into prior authorization and patient steering. So for all of our discussions about safety, I don't understand where in the existing legislation that has been presented where those guardrails are for safety. The bill language prevents plans from requiring the same drugs marked up by hospitals from being obtained from less expensive sources, whether it's white bagging or from other providers within our state who can provide comparable care and who are able to compete for business with the larger hospitals in Wyoming. Why would we choose sides in the provider community? We also don't understand why this bill is needed if hospitals have independently made decisions to prohibit white bagging from occurring within their own facilities. We understand some organizations would like to allow white bagging if it's possible, and if it's possible for them to choose right now, why do we need a state law that would outlaw it? If there is legislation which addresses the safety, timeliness, efficacy of infused drugs while reducing the cost, then we would be happy to engage that conversation. Unfortunately, the proposed language removes tools that insurers use to do exactly that, address the cost of very expensive infusions. If these tools are removed, we can look forward to uncontrollable sources of inflated costs. And the numbers that we just shared with you are a great source of where those big costs are coming from. When manufacturers and hospitals know that insurers will have to pay whatever is charged, then there are no upward bounds on the costs of already expensive medications. And I don't see in the proposed legislation where there are any bounds on the upward bounds on how much these costs could go. So therefore, we cannot support the legislation as proposed.
So, Ms. Roday, I know on the previous bill, we had some discussion that there had been in kind of internal conversations between your community and the hospitals. Are you, I think this is the Louisiana bill. I guess, have there been any conversations before today on white bagging and what, if there's some middle ground you can come to, kind of like the last bill, or is this a very separate
This is a very separate
topic?
Mr. Chairman.
Cool. Let's keep going to Ms. Mack. And then we'll take kind of questions once all four of you have presented. Go ahead.
Good afternoon, Chair Zwanitzer and Chair Baldwin and members of the committee. My name is Michelle Mack, and I am a senior director at the Pharmaceutical Care Management Association, which is PCMA. PCMA is the National Trade Association for the Pharmacy Benefit Managers, representing over 275 million Americans. I thank you for your time to comment on the issue of white bagging. Yesterday, we shared via email some background information, and if you don't have it, I have copies for you if you would like it. It's just some basic understanding of what white bagging is and how it's used, et cetera, and a little bit of background on PCMA. PBMs and their health plan and employer clients use specialty pharmacies to deliver high-quality, accessible pharmacy services while promoting product affordability. Flexibility to continue contracting with these select pharmacies is the key to ensuring access and promotability and promoting affordability in Wyoming. When an employer or health plan decides to contract with a PBM to administer their pharmacy benefit, they maintain authority over the terms and benefit plan design, including how drugs should be obtained by or delivered to beneficiaries. The employer or plan, not the PBM, makes decisions regarding cost-saving requirements, formularies, and networks, including the use of white bagging of a drug to a patient or a provider. We talked about a little bit about the shipping, and they talked about things being sent in a white bag, which technically back in the day when you went to the pharmacy, you got your drugs in a white bag. So I think that's where the white bagging comes. Sometimes when we ship drugs, they do come in white bags, but I have been to our specialty pharmacies. Our specialty pharmacies package these typically in boxes. They look at the weather, where it is being shipped from, where it is being shipped to, and they have algorithms, so it determines what kind of ice packs need to be in there and how long it needs to, it can stay refrigerated. And it's important to us because if it doesn't get there in the right amount of time, that's waste. And, we're doing this because we're trying to save money. Specialty pharmacy drugs, including injectable drugs with specialty handling, are usually shipped through the commercial mail. But a lot of these specialty pharmacies are shipped UPS and Federal Express, which is typically overnight. And I know sometimes that doesn't always happen. I'm from a rural area, so I totally understand how it works in rural areas. It doesn't always get there in 24 hours. Sometimes it's 48. But again, that is something that is looked at, and they package in, or they factor in extra time for those packaging and the ice packs. So in closing, specialty pharmacies and mail delivery are tools used in pharmacy networks because they ensure high-quality drug service, avoid waste, and ensure the appropriate use of medications. In limiting a plan sponsor's choices to allow white bagging, proposals to ban white bagging are likely to substantially increase costs for consumers and plan sponsors. As a matter of fact, our research shows that restricting white bagging in Wyoming would cost $213 million over the next 10 years. And that was included in your packet, and there's the methodology behind it. I thank you for your time, and I appreciate your time and attention to our concerns.
We'll go to Mr. Spencer next.
Good afternoon, Representative, Mr. Chairman, members of the committee. Bruce Spencer, representing the Mountain Health Co-op. Mountain Health Co-op, as I said before, sells policies on the individual market to individual Wyomingites, 20,000 of them, or close to 20,000 of them at the moment. The Mountain Health Co-op also has a very unique prescription drug program, not followed by, frankly, most insurance companies. Mountain Health Co-op covers with no patient expense, no copay, no deductible, a lot of drugs that are used for maintenance of chronic conditions. Insulin products, inhalers. These are expensive drugs on a monthly basis, but the co-op feels it's important to cover them with no out-of-pocket member cost because they want their members to be on their medication regimen, and they feel they save money by eliminating emergency room visits and things like that. The reason I bring that up is because if we can't control the costs of specialty medications, we can't offer unique benefits like that to our Wyoming members. A third of every healthcare dollar that comes in as premium to a health insurance company goes to drugs. Okay, 1/3. That's more than the actual medical costs that we're paying out for procedures. Half of that money, half of that third, is for specialty drugs. We have to be able to control the outrageous and enormous cost of specialty drugs. They do wonderful, miraculous things. They are also extremely expensive. And the one way we can control those costs is to use specialty pharmacies who buy in bulk and they pass that savings on to the health plan. And that's what white bagging is. We then buy that drug from that pharmacy for the member and we provide it to the hospital. If we are forced to allow the hospital to dispense that drug without getting the bulk discount from the specialty pharmacy, we're facing, as you heard earlier, up to 600% markup. I'm telling you, as a small health insurance company, that is an extremely serious financial concern. It will change the benefits that we are able to offer to people in Wyoming. And frankly, not for any good reason, other than certain providers want to be able to mark that drug up 600%. You don't see any safety sideboards that solve any of the problems that were mentioned earlier in this bill. None. You don't see the Board of Pharmacy up here saying that pharmacists are dispensing specialty drugs that aren't safe. I don't believe they are. Are there isolated circumstances where the drug can't be dispensed? Sure. Nothing is ever 100%, but I doubt very much that it's systematic. I doubt very much that the citizens of Wyoming are constantly facing risk due to white bagging. In fact, I know that's not the case, because if that was the case, this hearing room would be full. This is an extremely serious issue, particularly for a small health insurance company like Mountain Health Co-op. We have to be able to control these costs, and it's proven that using specialty pharmacies and white bagging does control these costs and is safe for patients. Both those things are critical for us to continue providing the service to Wyoming that we want to provide. We would strongly urge you to reject bringing this bill forward. If you want to discuss safety concerns and language in a bill about safety, we're happy to do it. But this bill isn't about safety. It's about money. And it's money that a small health plan like mine can't afford to pay. So we would urge you no. Thank you.
Thank you. Welcome.
Good afternoon. My name is Dr. Lugina Mendez Harper. I'm a pharmacist and I work with Prime Therapeutics. We're a pharmacy benefit manager. We're owned by several Blue Cross Blue Shield plans across the nation. And I'm here to just talk a little bit, give some basic information about white bagging. So when we're talking about white bagging, we're talking about clinician administered drugs. So those are generally infused or injected drugs. So generally we're talking about 80 drugs that have the potential to be delivered via white bagging. I want to be really clear about what's happening now. So the hospital pharmacies order their drugs from a wholesaler, a drug wholesaler, who delivers the drugs to the pharmacy in a powder form, generally, and they're reconstituted and administered. What white bagging does is simply, instead of the hospital ordering it from the wholesaler, a specialty pharmacy is the entity that's providing that drug to the hospital. It's also in a powder form. It still has to be prepared and administered, and the hospitals and their providers are compensated for that. So what we're doing is we're just taking that buy and bill option, and what we're seeing with that buy and bill option is the 200 to the 600% markup that the various health plans talked about. We're taking that excessive markup, we're still providing the same drug in the same format that the hospital pharmacies get it from their wholesaler in that powder form. They still have to reconstitute it, prepare it, administer it. But we're doing that in a manner that doesn't allow for that 600% markup. So, and I'll answer some of the questions that were asked earlier. The specialty pharmacies that perform this service, I wanted to use one of the terms that Representative Ward used earlier. We consider specialty pharmacies a concierge service pharmacy because they're reaching out to the patient to say, you have this chemotherapy drug, we're running to see, are you amenable to having this white bagged sent to your provider? When are you going? And we talk to them about that. Then we reach out to the provider to say, when is the patient scheduled to come in? And the reason for all of that is care coordination. And these medicines are mailed, we call it just-in-time delivery, which means that we are shipping it within 1 or 2 days so that it gets there right in time for them to be administered. The other thing with the specialty pharmacies that I want to make sure everyone understands is that specialty pharmacies are required to be accredited by national quality organizations, NCQA, URAC, things of that nature. And what those entities do is they require the specialty pharmacies to have solid processes and procedures for cold chain management. So if a drug has to be refrigerated, those specialty pharmacies not only have to prove and test how they pack a drug, but we also have to track the shipments. I know Michelle mentioned that we're tracking from the beginning to the end. We also are rerouting. So like I know when I was a pharmacist in charge at our specialty pharmacy, we were in Orlando and we were shipping to, I'll just say Idaho, and it was gonna go through Tennessee because of going through FedEx, and there were tornadoes. Well, we're able to reroute those shipments because we have a very systematic way of tracking those shipments. So there's a lot of hand-holding and like a concierge service is what's happening here with these specialty drugs. So I just want to make sure to share that with you. So anyhow, again, our issue here is just really trying to control the markup on the drug. It's unsustainable to have a 200 to a 600% markup. That being said, we as health plans and PBMs have come up with what we consider a market-based solution. And what that is to say, okay, Hospital X, if you want to continue to buy and bill the drug through your wholesaler, we're fine with that. We want you to join what we call an integrated dispensing network. So it's where we're going to let you buy that drug and bill us for that drug, but you have to have billing that's at or about what we would be charged by a specialty pharmacy. So that we feel is a fair solution. You still have the ability to buy and bill those drugs and administer them as needed, but we're able to control the costs by saying you have to, adhere to not these unreasonable markups. So that's some of the solutions that we've come up with in addition to white bagging to help control these costs. Because as Heather said, when you have one drug that's $1.9 million, that's a lot of tablets that you and I could get for a non-specialty drug. I mean, that takes care of a huge swath of people when you have $1.9 million in expenses for one medicine. So with that, I thank you for your time, and I'm more than happy to answer any questions I may not have touched on.
Senator Bouchard, we'll start on the left. Go ahead.
Thank you, Mr. Chairman. It kind of seems to me that we went full circle on these subjects because we talked about this very thing in Evanston at a committee. And so the 1.9 million, I'm having a problem here because those were through contractual agreements with the pharmacies. And why didn't you guys claw it back? Because I know you could. And so that's one thing. Two, there's a pharmacy in my county that, and this is why I'm saying we went full circle, they are an infusion pharmacy. And when the doctor says, hey, I want to work with that pharmacy, you've got the customer, the patient, where they're able to talk to the doctor and the pharmacy very personally, and in some cases right there in the infusion center. And that was one of the things that came up, that you've got somebody out of state, somewhere else, 800 number, and they're not going to get that personal care that's needed with these specialty drugs, especially when they need to adjust the dosage. So that's where I'm having the problem here. Now we're talking about, like, no, those things really aren't problems, but yet now I don't see anything in this bill. It does have a part that says that you should not reduce payment, but that would be great. I mean, that would work on its own, but you guys are in a contractual agreement already, so you could still run the clawback on it. Because I don't see where this bill changes that clawback.
Would you agree, or thoughts, Mr. O'Day, since you have the mic?
Mr. Chairman, Senator Bouchard, some of the discussions that we've had earlier had to do with the pharmacy benefit. And when we have these types of infusion drugs, that happens on the medical benefit side. So things work a little bit differently in that regard. When we have these particular arrangements, it is my understanding that these are driven through the contracts that we have with the hospitals. And so when we get this $1.9 million, that's what the hospitals are charging us. So it's a little bit different than what we've talked about before. And so I need a little bit more clarity about the second part of your question, because we have a pharmacist, we have 2 pharmacists that service our members here in Wyoming, and they are very involved with particularly these high cost drugs, because they are outrageously expensive.
You need a follow-up, Senator?
Yes, Mr. Chairman. So I've been in communication with some of the pharmacists here, and they basically gave me some of the concepts that I've talked about. But now I want to know, and maybe I'm going to have to ask the hospital pharmacies, I mean, do the PBMs affect them at all when they're making these decisions? Who's saying, no, we don't want to pay you? Who's doing this? Where is this coming from? Where is the control in your company? Is it through the company, the insurance company directly, or is this decision coming from the PBM?
Mr. O'Day?
Mr. Chairman, Senator Bouchard, it depends. It depends on where the benefit hits. And so I think that part of the concerns that we have with the wording of this particular language in the bill is that it doesn't look to us that we can actually help guide any of the business to some of those providers in the community that are outside of the hospitals.
So, one more, go ahead.
Thank you, Mr. Chairman. Can you tell me directly where it's in that bill? Because I cannot see where it still does not provide you contractual power in this.
And again, committee, this is just, I think, the draft bill from Louisiana, who was the first state in the country to pass something like this. And not that we have to copy them specifically, but the question before us is, do we want to proceed and have LSO draft a bill in this realm that would fit Wyoming law? So I don't want to get too caught up in the specifics of what Louisiana did, but maybe if I can tie that question, Mr. O'Day, when we talk about these markups in the hospital maybe being more expensive than a specialty clinic, your organization can look at those claims when they come in and say, hey, the average markup for most places should be here. We're not going to reimburse at that level, And you have that power to go back to the hospitals and saying, your markup was way above average for what we're seeing, and then have that discussion to lower? I mean, is that how the practice works now? You're not paying it out at that level when you get that $1.9 million claim. Are you paying it, or you're fighting it and saying, no, that you could have gone over here to this other clinic in town, paid $600,000, we're not reimbursing at that level?
Mr. Chairman, Senator Bouchard, so there's a lot in there. To Senator Bouchard's point, I think that there is the direction in the bill that talks about not interfering with freedom of choice with respect to providers furnishing the physician-administered drugs that ensure patients receive safe and drug therapies. So that's the part that we are looking at there. Mr. Chairman, to your point, the payment for the drugs that happen with the hospitals are through the hospital contracts. And so those contracts are renegotiated at different points.
But usually that's once a year, it's an annual, most of the time.
They depend. It's different based on the facility.
I don't know if anybody else wants to jump in. Some of you were nodding in all sorts of ways.
So, Mr. Chairman, Bruce Spencer with Mountain Health Co-op. That's exactly right. That 1.9 million would be reimbursed if it was within the contractual arrangement with that hospital. And Wyoming hospitals drive a hard bargain. So it's just a little bit more expensive here than some other places because they drive a hard bargain. But yeah, we can't say if the hospital's already provided that service and it's authorized, we can't say, but you should have gone over to the infusion clinic for 600,000. We can't do that. We need to pay at the contracted rate. So
I kind of get the sense that Wyoming hospitals would say sometimes insurance companies drive a hard bargain too. It's the joy of being a small state with very limited number of competition that, I mean, at the end of the day, you all kind of need each other, quite honestly, right? Because there's just not that big of a market. We all have to figure out how to work together, and there's a lot of money.
absolutely no question.
Yep.
You're correct.
Thank you. I have a question, but first, if I can touch on what you just brought up, because that was also going to be my question a little bit, is, I mean, we know that insurance companies don't reimburse what is charged all the time. But I understand if you have contractual agreements, then that's one thing. I would just like, this is a side note, but I'd just like to draw attention to the fact that here we're talking about knowing that hospital or healthcare costs are being intentionally jacked up 600%. That's the issue that we need to be dealing with. But that's not the issue today. So my question, yeah, my question on this particular subject is, so you heard the hospital pharmacist saying, we want the ability to adjust these dosages. So if you said 400 milligrams before, and it changed now since these labs came through this morning, we already have this drug in our possession at 400 milligrams, but now we need 450 milligrams or 350 milligrams. They want the ability to adjust that as compounding pharmacists. How do you guys feel about that?
Chairman Zonitzer and Representative Penn. When we design these programs, we consider all the potential dosage changes. And like I said, the medication is shipped in powder form. So it's still reconstituted. And at that point, you can adjust the dose. So we have that built in for that.
If I may, Chairman, what about if the dose increases? Do you provide extra quantity sufficient to increase the dose?
Right. So the other thing is that most of these medications are maintenance medications. So your maintenance as far as like you're getting them routinely. And then, as I said, the specialty pharmacies reach out to the physician and to the patient, and we have that just-in-time delivery. So it's not that like we're shipping this medicine 2 months before the patient comes in. We're coordinating that care closely and shipping that drug so that it gets there close to when it's going to be administered, and have enough in there that if needs a dosage adjustment within reason. I mean, obviously, if something dramatic happens, then we have to make some other adjustments, whether it be shipping another shipment or, whatever the case is. I know when I was overseeing our specialty pharmacy, we had overnight shipping. And then in cases of some of our hemophilia patients, we would have like within the hour shipping. I mean, it was dramatic, the things that we have to do. Again, it's based on the fragility of the patient and what's going on and what they need. But we have those mechanisms in place to help them and get that within 24 hours.
Okay, Representative Hornock, and over to Clausen.
Thank you, Mr. Chairman. So it seems like, or I'm curious to know, how long is this white bagging thing? It seems like a fairly new thing that has been invented. How long has this been happening? And, is it something that has been going on for quite a while, or is this fairly new in the healthcare industry?
Who wants it? Go ahead.
Chairman Monitors Baldwin and Representative Hornock. So as I think Bruce mentioned, the specialty drugs are something that we've seen just a dramatic increase in use. So when you look at the overall drug market, they're only like 3% of all the drugs that are dispensed are specialty drugs. But as Bruce mentioned, it takes up 50% of our drug spend. All the money that we're spending on drugs, 50% of that money is going to specialty drugs. So as we've seen these great innovative therapies come out with these astronomical price tags, we've had to figure out how do we control that. So it is a more recent phenomenon, but again, it's in response to the fact that the list price of these drugs are so high. Even $500,000 for one drug, that's the cost of the drug that Heather used earlier. I'm dating myself, but 20 years ago when I graduated from pharmacy school, we would get nervous when we had to tell somebody, oh, it's $50 or more, and now you're in hundreds of thousands of dollars. And again, that has to do with the innovation that's happening. So it is a relatively recent phenomenon, but it's in response to the explosion of, personalized medicine and just really kind of getting in there and getting specific therapies to deal with specific issues. And again, it's really in response to the fact that there's such a high price tag and high cost there that we're having to do whatever we can to make certain that we control those costs.
Thank you, Mr. Chair. So I guess, first, in my wife's case, it was not just in time. It was late, right? So come back next week to Denver from Wyoming. So take a couple of extra days off work and drive an extra 800 miles because the medicine did not show up in time. So my question to Ms. Rodet, I'm used to signing contracts that hopefully I get 160% of what Medicare reimburses for our services. Do we see that in pharmacy? I mean, do you guys sign contracts that say on these specialty drugs, we'll pay a certain percentage of the hospital above what Medicare pays? How is this different from other services?
Ms. Rodet, or if you want it.
Mr. Chairman, the contractual parts are different. So if it's under the medical policy, then it happens under the facility, the hospital contract. But if any of the specialty drugs come through the pharmacy benefit, and Lugina can probably explain it better, then it goes under the PBM contract.
Chairman's Monitors and Chairman Baldwin and Representative Clausen, I think that really is what the issue is here, is that in the hospital world, it's billed as a bundled service. You've got the medication, you've got the preparation, the administration, and the clinical care of that patient is all bundled in one payment. And so in general, PBMs are not involved in hospital pharmacy because it's billed under that medical benefit. Where PBMs do come in is when it's billed through the pharmacy benefit. So when you start to use these specialty pharmacies to provide the drugs, then we're involved, and that's where you have those contracted rates. And that's why we're able to control and say, you will not charge 600% markup on this.
Barlow.
Thank you, Mr. Chairman. So with the absence of having the entire Louisiana statute book in front of me, there's some presumptions I have to make. And one of them is that a participating provider is actually in network in-network, the way this legislation is drafted or has been passed. So my question is, if we did something similar to this, it seems to me that it would change the in-network approach that you took with all of your providers. And that, in fact, costs the health insurers, the insureds, whether they're employers or individuals, more money. Am I reading this incorrectly? I mean, there'll be more out of network care being provided. It looks to me like the way this is drafted, because this is only drafted for, the way I read it, in-network type care. Thank you.
Mr. Chairman, Senator Barlow, one of the things that happens when we start taking bills from other states is that, and we sort of like pick and choose, right? I don't know where in the process this Louisiana bill came from. So to your point, there may have been, and perhaps my colleagues who deal with this more on a national level than I, there are other bills that sort of were foundational that this sort of came up, that this came on top of. And so I don't know what it's building on. And so I'm afraid that I don't know how to answer your question. I think it's important to understand the context of that Louisiana legislation.
And Chairman Zwanitzer, Senator Barlow, I know that bill passed in 2021, and I know that there was a lot of discussions, which there always is a lot of discussions on bills, and, things go different ways. But, and actually, as far as we're concerned, there's only a bill that is in Vermont, and then there was a Board of Pharmacy issue that deals with this. Now, this year, I know that there's a couple other states, actually a lot of other states are looking at this issue, but legislative-wise, we really don't know what the impacts are because it's really so new.
But it is probably fair to say that once Louisiana put a bill like this into place, nationwide, every state is going to start working in this area, and you're going to have a lot of travel coming up, probably. And so is there any kind of model? I mean, if it's not this kind of legislation, is there anything you're working on with your counterparts in the insurance world to, try to find an alternative approach or a better approach, boilerplate language that you're working with other national organizations in the medical field on trying to get this right as drugs keep getting more expensive?
And Chairman Zwanitzer, this bill has literally exploded in all of the states. Again, we always, when we come into a state, we always want to solve for the state's problems and the issues that the state is seeing, not what other states or national, agendas are. And, we're hearing there's safety, it sounds like there's some process concerns. Those are things that I think that we could really talk about and solve, because those are the problems that are here.
Chairman Zwanitzer, I just wanted to address this. We had a bill in Utah this legislative session that was very similar to what's proposed here, a white bagging and a brown bagging prohibition. And when we had stakeholder meetings with the large health systems in Utah, as well as the insurers all around the table, what we discovered was that a lot of the larger health systems had policies and procedures in place that prohibited white bagging. We then talked about the integrated dispensing networks and said, this is something we can do. So if you want to continue to buy these drugs and bill them, we have this opportunity for you to do that as long as we can control, within reason, the markup for those drugs. And ultimately what we ended up doing is, or what Utah ended up doing, was passing a legislation that prohibited brown bagging for safety concerns. And that's where we landed because, the legislators were swayed by the fact that, we have to control these costs and we can't have unchecked markups that are unnecessary.
All right, Senator Bouchard.
Thank you, Mr. Chairman. So we're talking about costs. And I got to ask, how much do lawsuits cost? Because I see a case that was just filed last month where after being told that you guys can't withhold payment, but yet looks like Blue Cross withheld payment of in excess of $250,000. And that's what the lawsuit basis is on, an infusion that came into Wyoming and didn't get paid. So it seems to me we're driving up, I mean, that's not 1.9 million. We're talking about somewhere under 300,000. And it seemed to me that lawsuit's going to cost way more than what the cost of the medicine was.
So, Mr. Chair, as a lawyer, I'm going to, Bruce Spencer of the Mountain Health Co-op, I don't believe that the representative from Blue Cross can comment on active litigation, and that so kind of puts her in a hard position. I will tell you, though, I don't think the lawsuit's going to cost 1.9 million, and that's one drug for one patient. So the cost of the lawyer fees in that suit is not going to be as high as that one drug for that one patient.
Well, go ahead if you want, Ms. Roday.
Mr. Chairman, I just want to confirm that I'm not allowed to comment on current litigation.
And I think we're all trying to get to the same place. You all don't want waste. I mean, you heard what the Hospital Association is saying. They don't want refrigerators full of drugs that are going unused, that they're not compensated for. It's not in patient care safety. You certainly don't want that as well. And so I'm not sure we're on the same place of coming to the table on this one that you might have been on the prior authorization.
Correct.
Primarily because we're about the last state when it comes to prior auth, and we're kind of in the emerging area on this one. I guess I just wanted to say that and see if there's any thoughts in your mind that there is a place that we're going to get to on this one that you all, think we can move the ball down the field.
So, Mr. Chair, I first want to, you said something that I don't think is correct. The hospital is not out of money on these drugs. The health plan has paid for those drugs at the specialty pharmacy, and then they're delivered to the hospital. So the hospital is not out of money with the drugs. In terms of safety, I think we've said we're willing to discuss safety provisions, but also at the same time, if hospitals want to dispense, then we would like to have an agreement that the cost of dispensing that drug is going to be reasonable.
And that's just the dynamic marketplace. If we were to put something into place, I would imagine you would renegotiate all your contracts and the cost of healthcare would go up for all Wyomingites. But that's kind of the danger on the backside of what we're talking about is cost containment, but it does have an effect on everybody, every individual in a health plan. Senator Hutchins, questions?
Chair, I do have just a few. And one of the things I seem to like Mr. Spencer's markup or your health plan. Sounds like it's perfect. Everything you do just sounds awesome. One of the things I'd like to know is could we have the hospital come back up and defend that $1.9 million markup? Kind of give us an idea if they know why that happened. Then I'd like to know, also state that in the bill, I don't see anywhere or the hospital saying that they want to stop white bagging. They just want to deal with the issues that they're having and get an answer from you guys on anyone, the costs that you're incurring with the wasting drugs in the hospitals, refrigerators, it seems like that's a big cost. Someone also mentioned that their parent needs that drug maybe within hours of testing. How are you going to be able to provide that within hours? And if the hospitals are here in Wyoming telling us that there's a problem, and you're saying those two of you that are in Wyoming, no, you're not having this problem, why aren't you guys getting together instead of coming to us to tell you to get together?
So let me try to, I might deflect some of those just on the, whatever the dispute is on that one, whatever hospital, whatever drug it was. I think you can handle that internally without that being an issue before us. And I do think we discussed a bit about that you try, in many cases, to get the drugs just in time, as you also heard from some of us up here. That doesn't always work, and it causes significant concerns. And I think we can all agree to blame the federal government and the U.S. Mail Service sometimes. And the other, I think the questions were, yeah, I mean, we have to refrigerate drugs. There's a cost for all this. And it's really, how do we get to a place where, you know, it's about patient safety, welfare, and trying to eliminate the costs that go into patients who are especially having difficult times on these drugs. So I'm not sure if there's any other questions you want to respond to on Senator Hutchins that you hadn't already previously mentioned, but I'll give you that opportunity if one of you wants to jump back in. Didn't see any. Okay. Any other questions for this panel? I know we're running a little late today, and there might be a couple more people. Don't go too far. Appreciate you all being here today. Other people want to talk about white bagging in the audience? I do appreciate your patience on pace for the last 4 hours. Any other white bagging thoughts? Senator Hutchins.
And
But if I got them wrong and you want to call somebody
I
up,
would have liked an answer from them on the issues, not from us, because we don't have those answers. When the hospitals, the pharmacists, medical community is saying this is happening to us, and then we get a group saying, no, it isn't. What's the answer? So can someone answer it or not? Because you're going to just leave me in limbo. And that's okay.
I think there can just be disagreements to the extent it's happening and what the ways to solve it. But Mr.
Thank you,
Boley's going to
Mr.
come
Boley.
take a stab at it.
Mr. Chairman and Senator Hutchins, I would just say that we have tried to work on this, and this is not something new. We let the insurance companies know that we were interested in this during the legislative session. We even considered potentially bringing something during the legislative session, decided it didn't make sense to do it at that point. We had a 2-hour meeting 2.5 weeks ago at the request of Blue Cross Blue Shield in our office, and we discussed both prior authorization and white bagging. We're interested in solutions, and we're interested in working with them. We asked for potential solutions or compromises on both of these issues, and did not receive anything. Reason that we submitted the Louisiana legislation is because that's basically what we had. We don't think it's the perfect thing, and as I talked with the chairman about this, we submitted it so we had a starting place. And I think we still have a starting place. There are a lot of unanswered questions. There's a lot that still needs to be done, and I think we can do it in a collaborative manner. We actually tried to start that process, and we're committed to continuing that as well. But we do believe that more than likely, we're going to need your help as well to put something into statute when we come up with that. And if we draft something now and give us a starting point, I think at least we have something to work on that we can start chopping up and making Wyoming specific. So thank you, Mr. Chairman.
Thank you, sir.
Senator Barlow.
So, Mr. Chairman, I think I understood that this bill was passed in 2021 in Louisiana. So has it been implemented? I mean, has it gone through whatever rulemaking? I don't see rulemaking required in it, but I don't know how Louisiana works. So is it actually implemented? And what has been the impact, let's just say, on their employee group, state employee group insurance plan? If you know the answer. If we don't, then I think we need to know the answer if this is actually being employed. Thank you.
Mr. Boley, if you do.
Mr. Chairman, Senator Barlow, I did see my counterpart in Washington 5 days ago and ask him about this, and to my knowledge, it has been implemented. I don't know the impact though, and I think that's something that we could look into.
Anyone else? Seeing none. Okay, you gonna make a motion if there's no, make sure there's no public comment online?
No.
You're not making motions yet. Senator Barlow, go ahead.
Making any motions. Mr. Chairman, I guess I would like to know if we have another significant payer of healthcare in the state of Wyoming, for the state of Wyoming, that's our workers' comp program. Do they have any input on this issue, or don't deal with any specialty type things? Okay, thank you. Thank you, Mr. Chairman.
No for the people at home.
That was a no from the Director of Workforce Services, Director Cooley. Thank you.
Okay. No other public comment on this? So committee, I guess the ask before you is probably a bill draft for our next meeting. modeled after the Louisiana law into Wyoming-specific statutory language, to continue working on the issue if we want to discuss it this interim. I don't want to exactly put those words in anyone's mouth, but I believe that's why it's on the agenda, and that is what the hope from the proponents of doing something were. So if there's a motion, Senator Bouchard.
Yeah, Mr. Chairman, I mean, I'd like to motion that we start a draft, and then we can come back and look at some of the specific issues that we've talked about. I think also we need to look at maybe this court case and dig into it and look and see what's going on a little further, and that'll help us in the bill draft.
Is that a motion?
Yes.
So the motion is to, it's already seconded, and the motion is to get a bill, oh no, it's seconded by you, Ahern, for a bill draft for our next meeting. I don't want to put words in your mouth, but modeled after the Louisiana law, Wyoming tailored, and then at least we have something we could all review with our statutes, continue the conversation, and then encourage the people to work together in the meantime to see if there's some agreeable things that we can move the ball forward. That's the motion. Discussion. Senator Barlow.
Thank you, Mr. Chairman. So in light of that, if that's the motion, I'd also like there also be a parallel research project that looks at what Louisiana's actual costs, what has changed, and then a fiscal note supplied at least by our state, our EGI program, to know, so we know what the impacts might be, because that's what will show up in our budget. If we pass this bill, we will be paying for the EGI component of this, or the employees will in some way. Not to mention all the private insurers, TPAs, third-party administrators, everybody else. So I think we do have to understand the fiscal impact of this. And personally, Mr. Chairman, I hope we also are looking at a limiter, whether it's Medicare, 200%, no more than 200% of Medicare or something, as a upper limit to this, because it's not sustainable leaving it open-ended in my view. Thank you, Mr. Chairman.
Anna and, yep, took those comments in. Okay. Please. And Mr. Hayes, if the motion passes, we'll trust that you'll bring us some stuff at our next meeting, if the motion passes. Further discussion, Representative Hornock.
Thank you, Mr. Chairman. So I can't help but wonder if we're not getting a little bit ahead of ourselves on a bill draft. To a point, it seems like the day has been mostly, which oddly enough, the Chancery Court is held also in this building. Seems like we have become a little bit of a Chancery Court between two entities that are bickering or disagreeing here and there about various, both have a great incentive, which is not wrong, for profit. But it seems like to come to before this body is a whole lot cheaper than hiring attorneys and going before a Chancery Court to figure it out. Now there's some nuances that we need to figure out specific to Wyoming, but to a certain extent, it almost seems like we're a little bit ahead of the game here, that we need to somewhat allow the free market to kind of play itself out and work out some of these situations before we enact legislation and put a stop to something without understanding all of the potential unintended consequences to that legislation. So, that's just my perspective on the way that I see this. I think this is a topic that maybe we do need to deal with, but I don't think that this is really the time. I think that there's some entities in the room that have come before us that need to discuss and work this stuff out. And then there's probably some regulation around how they work things out that we could probably deal with. But anyway, that's my comment.
The joy of public policy. I'm sure some people think we're going too fast, and other people think we probably waited too long already, right? If it was easy, it wouldn't come to us. Senator Hutchins.
And this is maybe to kind of speak to what Representative Hornock is speaking about. I get where he's coming from, but it was mentioned by one of the players during one of the meetings last year, we've been working on this since 2015, and they just keep coming back and coming back. This is an issue with multiple heads that we've been dealing with for years. And it may seem fast, we're fast tracking, but I don't think it is. I think we need to address it, or it's just gonna get worse. We need to start slaying the dragon, if I could use that word. Just kind of get some control on this whole process. And when you hear that they've already talked, they came together 2 weeks ago, 2-hour discussion, and nothing came out of it, we have to kind of intervene because they're kind of making us. So I don't think it's gone so fast. I will get with you and introduce you to some of the players so you can hopefully understand a little bit more and understand why this is happening. And hopefully that'll help. If that helps everybody else. I'm willing to meet everybody.
Further
Thank you.
discussion. Thank you. Senator Bashir.
Mr. Chairman, I just want to add a little bit to the free market discussion. You could probably take anything about the free market and throw it in the wastebasket because you only have 2 insurance companies. Prior to that, we had a free market. That's gone. And that's why we have a problem now.
All right, for discussion on the motion. All those in favor of the motion, please say aye.
Aye.
Opposed, say no. That motion is carried. LSO, if you would put together a bill draft for our June meeting, and Donna or whomever, any work on the Louisiana legislation and some costs would be great. Mr. Hayes, we would go through and do some research on how that might affect Wyoming payers, specifically EGI. Anything else on white bagging or brown bagging or clear bagging? I suppose we could take a 5-minute break. I know the 3 of you have been waiting for hours, but if you're okay for another 5 minutes, let's take a 5-minute break, which really means it'll be an 8-minute break, and we'll come back at 3:15 to discuss PACE. We will begin as soon as Representative Chadwick returns to his seat.
Yes, thank you. Double time.
Ms. Johnson, welcome.
Thank you, Chairman Zolana. Sir, I just had one comment. Regarding fiscal notes, we don't generally do fiscal notes until a bill is numbered. We just don't have the capacity to do that. So that's not necessarily something that we're going to be able to do on these draft bills, just so you're aware.
We'll call it a preliminary fiscal impact statement.
Would you like us to just maybe reach out to an agency and see?
Yeah, I think when you get a draft prepared, Mr. Hayes will look at that and try to give this committee something that doesn't have to be finalized.
Doesn't have to be formal.
Doesn't have to be formal. It can say, here's our rough cost.
Mr. Chairman?
It'd be nice if he has a page of some data instead of just a number on a napkin. Yeah.
Was Senator Barlow's question also what it was costing Illinois?
Louisiana, we
That
mean?
was the fiscal notice also.
And so some research on what Louisiana we think is paying, if we could talk to their department and see if we get that information as well. Senator Barlow.
Mr. Chairman, so Commissioner Rude has volunteered to at least reach out to them and get some feedback from them as well. So maybe, thank you very much, Commissioner.
Next up committee on our agenda is the Program for All-Inclusive Care of the Elderly, commonly known as PACE. This was a program we had in Wyoming previously. With budget cuts a couple years ago, went away. And as I think people, I think in both sides, certainly in the House, you will remember second reading amendment. We tried to refund it for a couple of million. And then there's some concern that we needed a long-term, more consistent approach, that a couple years of funding wasn't going to do it unless we could commit. And so I think Senator Baldwin also brought a budget amendment on third reading for us to study it in this committee in the interim. And so to join us today is Ms. Brocious from the Wyoming Primary Care Association, really just to give you some information on what the PACE program is, certainly what it was in Wyoming, what it's doing in other states, and answer any questions you might have. So with that, Tracy, the floor is yours, and I believe we have a slideshow presentation ready to go. Okay?
Yes, we do.
Welcome.
So, good afternoon. I'm Tracy Brocious. And while it says I am the interim director for the Primary Care Association, really I'm here on behalf of the Healthcare Task Force that I've been sitting on for the last couple of years. And so Katie, so we didn't have any snafus with technology. Katie's going to be advancing the slides for me. So go ahead, Katie. So over the last, kind of during the pandemic, Governor Gordon brought together a healthcare task force. And early on, we had 4 subjects that kind of rose to the top. And our aging population was definitely one of those. I had the privilege of leading the subcommittee that looked at a lot of data and a lot of opportunities that potentially we would want to explore across the state. So I'm really here on behalf of all of those folks today to kind of explain some options up to including PACE. So I was also involved with the PACE program in the past, so I can speak to some of the details. But really the task force committee looked at the data. So we dug through a bunch of data, and one of the things that we are quite concerned about and I wanted to discuss today is the very fast pace of the aging population in Wyoming. One of the things that we talked about is that the state aging plan, the plan on aging, estimated that we're going to be the second oldest state in 2030, right behind Florida. So with the small state and narrow resources, we need to be looking out for this ahead of time. And so the committee was very concerned about making sure that we kind of knew what that looked like and the service and the capacity that we currently have. So just to kind of give you those, I know the numbers and stuff on the screens are very small, so I'm just going to call out the $312 million that potentially this population in 2030 could be costing us. So that's really the big dollars that we're discussing. So Katie, if you want to move forward. So this is a nice slide from our chief economist with the state of Wyoming that she put together. And her comment was, ever since the first baby boomers started turning 65 in 2011, there has been a rapid increase in the size of our older population. And so by 2030, we're projected to have 135,000 people in the state of Wyoming that are over the age of 65. And you can see by those bars there that that is a significant increase for us. If you dig through the data just a little bit, it also is that we are aging not just in place, but Wyoming is attracting folks in retirement. So we're actually importing kind of folks that are going to be aging into that population, which a little bit compounds our problem. So Katie, if you want to move to the next one. So that kind of gives us a little bit of a challenge, right? So if Wyoming's going to have the highest proportion of baby boomers and one of the lowest proportions of Gen Xers, that kind of creates a potential ongoing staffing challenge. So as those folks are aging, and that kind of dip in the middle is really our seasoned workforce. So one of our concerns is that we need to be on the radar is the sufficient workforce to take care of that senior population. All right, so if we'll move forward then, so now, okay, so great news, right? 135,000 people. That's 20% of our state population by 2030, which is actually just around the corner. So if part of that, if we look at kind of our experience in the past, in 2016, 63% of the patients that we had in nursing homes were on Medicaid. And so that is obviously a huge state expense. And that has kind of been the trend. But I want to talk a little bit about what that looks like and potentially some of the changes and differences in the population. Our past can help us with kind of forecasting, but the population and those baby boomers that are aging into that category are a little different. And a lot of that population wants to remain at home for as long as possible. And obviously during the pandemic, et cetera, you know, being in congregate settings is not ideal. And that is really the last place that folks want to spend the rest of their lives. So really, what are our options, right? Like, so what can we do to have people age in place as safely as possible in our communities and really be supported? So Katie, I want you to back up just 1 second though. So one of the things I want to mention is that in 2018, this is hit not only us, but on a national level. It is an increasing challenge across the country. So in 2018, the Trump administration sent out a letter and said, hey, right, this is impacting the Medicare trust fund, it impacts state budgets, plus then we have a whole population that we need to look at. The cost is one of the things that is driving a lot of this, right? So those individuals that we're going to talk about in that what we call dual eligible bucket, which is where they're Medicare and Medicaid eligible, while they only account for 20% of the Medicare eligible or that age bucket, it's 34% of Medicare spending. On the flip side, in the state, in a Medicaid environment, while they're 15% of the enrollees, they're 33% of the Medicaid spending. And I know Director Johansson's probably going to talk about the cost to the state budget on this type of population. So it is definitely something we all need to have kind of on our radar. So that letter in 2018 outlined several opportunities that the administration was encouraging states to consider and to research, because none of these programs are easy to get off the ground. They do take some very deliberate planning and multiple people and collaboration between the various entities. So Katie, you can advance that now. So A couple of the programs that we did definitely look at as part of the task force were two situations. One are called, it's a managed care program that takes these populations in what's called a DSNP. And then the other opportunity that we're going to talk about more specifically today is the PACE program and the interdisciplinary approach to potentially this population and the needs going forward. So Katie, if you want to move forward just a second. So let's talk, I want to just make sure that we talk a little bit about the vocabulary, because it's very important for us to understand kind of the qualifications of this population. So, and there's very big differences between the Medicare Trust Fund and those funds, and then the Medicaid funds. So under Medicare, that's a federal program for health insurance for those over 65 or those who have disabilities and end-stage renal. So this really, everything we've been talking about today throughout the day, it talks about hospital services, outpatient services, pharmacy. So when you turn 65, right? So your Part A benefits, there's very deliberate differences under the Medicare CMS policy. So your Part A takes care of your hospital visits. Your Part B does all of your doctor's visits and your medical services in the outpatient setting. Your Part D is where the prescription drugs come in. And then under the Medicare, if you bundle all that together and do a Medicare Advantage plan, it bundles all the A, B, and D pieces together and gives those options. So that's important, because what we're going to talk about is what happens when you're able to use the Part C options that CMS has available to actually look at what you could do with that in a Wyoming setting. Now, if you shift gears a little bit to the population we're going to talk about is under Medicaid. So under Medicaid, Medicaid is funded both with federal funding and with state funding. And it is provides the low-cost health coverage for a very defined population. So this is those folks who we're going to be talking about are for the nursing home care. They are citizens, they're over 65 and or blind and disabled. They are medically eligible and qualify from a public health and a clinical status for additional clinical care. But most importantly, they are already in a place where they are financially vulnerable. These folks would have an income on a monthly basis that would be lower than $2,700. That would include all resources, whether it be their Social Security, any retirement or pension dollars. And then their assets, this is a Medicaid eligibility, would be essentially cash in the bank of less than $2,000. So I just want to point that out, because we are talking about a sliver of the population that is financially vulnerable in the fact that they are low income. They have spent through potentially most of their assets, with the exception of potentially if they've owned their home. And then also clinically, they have reached a stage where they are no longer, they need assistance, right? They may be safe to live at home, but they can't do everything, right? So they need assistance, what's called acts of daily living. So that's just the population that we're going to specifically talk about today in the next couple slides. And then at the end, I'm going to back up just a little bit and kind of zoom out a little bit about population that we need, that 135,000. So the program for all-inclusive care of the elderly is a comprehensive model that was developed in the late 60s, 70s. Really a grassroots kind of project that developed, acknowledging that seniors want to stay in their homes as long as possible, and so it's really targeted in this case at those dual eligibles where they have Medicare benefits, but they've also hit that place where they've got Medicaid benefits. So in this case, they would be eligible for the PACE program if they were 55 and older, had qualified for those programs. They live in a PACE service area because the program is very defined as far as a geographic area. They are eligible clinically to either be in a nursing home, or again, they hit that clinical level, but they're still able, with assistance, to live safely at home. That's the target market that we're looking at in this type of program. So Katie, if you want to move forward. So really PACE is the theory, and the way the program is built in the regs is that it's a patient-centered, community-based alternative for people who can continue to be at home and not be in a nursing home. Now, so that's the care model. But the financial model is a full risk, financial risk program, a capitated program. So what happens is that remember, we've got the Medicare funding and you've got Medicaid funding. So what this does is it takes the Medicare funding and says, hey, if we could maybe care manage patients and use the dollars in potentially a slightly different way, could we get better outcomes for that same money, or hopefully less money, and be able to keep people safe and give them a quality of life without having to move to the nursing home. But at some point, some patients eventually hit a place in their clinical kind of journey that they are no longer really able to be at home without full-time care. So that's the model. So, but the PACE program is very deliberate. It reuses an interdisciplinary team. So it has a whole team of people that partner with the patient and caregivers if they are involved. They continue with plans of care. They have a very deliberate way of approaching it. So it's very integrated. And it looks at, and the program is at full risk for if that patient goes to the hospital, all the meds that they need, and anything they need to be able to stay at home. Or ultimately, if they have to move into a nursing home, the PACE program is responsible for paying the rate at the nursing home. So I'm going to move on, Katie. So the program is very structured. It has been developed over the last 40 years and has amazing clinical outcomes. It does have some requirements. The requirements are a lot of built infrastructure. So for example, it requires an adult day center so that patients have social interactions, because that's one of the things as people's age is they lose their social circle. And that social isolation can really exacerbate clinical outcomes. So a lot of times in these adult day centers, there's physical and occupational therapy that happens, recreational therapy, meals, social work, and again, that personal care. There's also dedicated medical staff, home health staffs that can go to the, do all the home visits. And then the prescription drugs. So here's the beauty of the program. And I would say this program for this population is considered kind of the gold standard, because it is required that regardless if the facility, if the patient needs it, the program is supposed to be able to provide the service. That's the secret sauce. That infrastructure piece, though, is very difficult to build on the front side for programs, and that's usually where the upfront cost comes in. So, Katie, I'm going to have you move forward. So that really model of care then is the way this works in the background, right? So that's how the patient would experience it. There's this team of people that's scooping them up, right? Potentially a bus driver noticing a patient who's not doing well and gets them to the clinic before they have something that lands them in the ED, that kind of clinical. But the way it's actually created and the infrastructure behind the scenes is there's a three-way agreement between CMS, the Centers for Medicare and Medicaid, on the Medicare side, The state Medicaid agency, because again, it's leveraging those Medicaid dollars that would potentially be paying for them either in the community or in a nursing home. And then the individual organization that's running the program. So it's a three-way contract, binding contract that sets out whose responsibility is what. So under Medicare, Medicare would then pay a per member per month. Medicaid would pay the per member per month. And then the PACE organization's responsibility is to provide all of the care to that patient population. It is a capitated program. So that those two payments blended together for each one of those patients is to be that is all the payment that that organization is going to receive. There is also one other piece that is a positive for these patients is there's no out-of-pocket for these patients. There's no co-pays. So for these patients who have struggled to meet potentially their Medicare Part B out-of-pocket or something like that in the past, or hit their deductibles on their Part D drugs, the program is created in a way that they don't have all of those expenses. So it allows them also the financial security to be able to stay at home. So Katie, if you want to advance to the next. So the challenge with this program is it's very complex on an operational side, because it requires the PACE organization to run a health plan. You are the Medicare, you are the health plan that's paying all the bills. So if a patient goes outside of what you have built internally as your network and receives services, say, for an audiologist, or at they go to the ED, or they have a transportation in an ambulance because something happens, the PACE program is the payer. It is the health insurance that's paying those claims. So it requires the PACE organization to have a network, have contracts, etc. It also manages all the pharmacy. And this is one of the pieces that makes the PACE program and some of the documentation that I sent you, should we advance into kind of the more of the details and into the grass, is the pharmacy drugs. Then in this case, the PACE program also helps manage all the pharmacy. And so there's a whole complex process that goes behind the scenes on actually projecting pharmacy costs and drawing down. And so again, you're a health insurance for the pharmaceutical piece also. So all of that to say that it's complicated, it's not undoable, but there are a lot, because it is a standardized program at this point, there are expectations both for all three of those partners in that three-way agreement. Now, in where this kind of came up and bubbled up in the early 2000s, there is already a state statute that requires that the PACE program would be essentially reimbursed, that the Medicaid would be automatically be at 90% of what it would cost if that patient was just in the general population. Now, obviously, that also takes a lot of background calculations, etc. So again, it's a health plan and you have to calculate that cost. So Katie, I'll have you move forward. So I'm going to shift in just a little bit. So I'm hoping you understand, I'm kind of conveying because I can't see anybody. So I'm hoping I can conveying that this isn't something that you stand up right off the bat. It is a journey. It is an investment, and it is an investment, and it needs to have community support. And in this case, our experience was in Laramie County, the hospital, Cheyenne Regional, the board, and we had some community outreach, went through the hard work of doing a full application and getting this up and running. So part of that program and part of the requirements when you apply for this type of program with CMS is that they want a essentially like a pro forma. how do you know there's a population that needs to be served? What does that population look like? And then also making sure that financially you're going to be able to serve that population. So Laramie County and CRMC did that back in kind of those early 2000s. And what the pro forma said is that there should be about 64 patients that would qualify for the PACE program, right? So the whole original PACE program was built to have a patient population of about 64 people. So the PACE program, they got it off the ground, everybody was on board. And in February 2013, the PACE opened up. What was the experience was within 18 months, and that pro forma said in 4 years they would get to 64 patients. But the experience is that there was so much built up need in the community that they hit that 64 mark of patients eligible in less than 18 months. And by 2020, it had expanded to 143. And the restriction really at that point was because we were out of space, and we built a new facility in order to be able to expand, because the response and the need in the community outstripped what the projections had been. So that explosive growth is a learning lesson that we can take, that the local need was so high and we had underestimated that. So where we had, and I will speak on behalf of the folks who ran this program, is that the intent was that if you get one of these off the ground, you have all of that infrastructure, you have the health plan built, you have all that really heavy stuff built, that then you can then go forward and potentially create another day center and target another population, potentially in a different county, and copy and paste by building on the foundation that you have actually created. The challenge is the explosive growth in Laramie County alone, which is where the host organization, which was CRMC, experienced it, is they had so much need in their own community that it kind of impeded that long-term vision of the copy and paste into other areas. So I think that's an important learning lesson for us is as we look at models going forward, in also looking at the 135,000 people that will be in that potential eligibility bucket, that we need to keep that in mind. So really PACE was built from a really community need. It was built as a clinical, because we were seeing it as a clinical need in the community. But after kind of getting our feet under us, and the initial investment, it was a self-sufficient program. But I do not want to underestimate and tell you that it is an easy program to run. It does need some deliberate skills, and it definitely needs that three-way agreement. It takes all three parties to be effective in order to make this work. So I think that is kind of a high level about PACE, but as far as this conversation moving forward and going back to the task force, one of the things that we looked at as the task force is that when PACE was created in the 60s and 70s, it really was the only there was, a unique program. And since then, there have been other innovative things, especially early on in under the CMMI challenge grants in the, like the 2010 area time period, really looking at how could we, not just we, but we as a nation can do healthcare differently. And a lot of creative things came out of that. So PACE is an option, but there are also other options that potentially we may want to look at. And some of them are listed here. Some of them, and the beauty of what we have is that Wyoming has a lot of restrictions, right? But we also have a lot of very passionate people, and we also have a high need. So what we can look for is things potentially to maybe take pieces and parts of other things and put them together and really wrap services around our population. So we're a small state. We're very spread out. The complexity of running this kind of any type of health plan, I'm sure you heard about all the pieces and parts today. Those are the things that we need to think about as far as options. But I don't want to underestimate the fact that those 135,000 people in less than really about 5 years, right, is going to be a high need population. Now, they may want to stay home longer, but if we do not have the services in our communities to take care of them, it won't matter if you have money. And so PACE is really targeted at that low income and dual eligible population. It really works for that population. Our challenge is that I would think we also need to look at all those other aging folks who we don't necessarily want to have to spend all the way down all of their life savings or sell all of their assets in order to be able to pay for care. How do we scoop those folks up and look for solutions for those also? So I know it's been a long afternoon, and so I'm going to quit and I'll just take some questions. And Chairman Zwanitzer, if you have anything specifically that you would like me to touch upon, I can answer.
Thank you, Ms. Brocious. Questions, Representative Ward.
Thank you, Mr. Chairman. Mrs. Brocious, did the PACE program require elderly patients under its care to be masked, vaccinated, or tested in the last 3 years?
Ms. Brocious, if you know, but I think it ended before the COVID outbreak, but were there other requirements for vaccines, masks, et cetera, in the facility?
So actually during the pandemic, because the PACE program was defunded during the pandemic, at that point in time, we had been bringing patients into the clinic in a masked capacity, but for the most part, we had everybody social distancing at home. And that it closed prior to there being vaccinations available.
Other questions? Guess I'm not seeing any other questions from the committee. Maybe a long day, huh? All right, anything else you'd like to add? Nope. Representative Hornock.
So, thank you, Mr. Chairman. Appreciate the testimony and all of the information that we've gotten. One thing that I haven't seen within the information is an estimate of what you talked about being that upfront cost. And so we're dealing with day centers, that's physical buildings, medical staff, prescription drug programs. We just talked about white versus brown bagging. I'm not sure if, that'll have to be dealt with maybe by us and you. The transportation costs of vehicles, the respite volunteers programs, staffing, and then scaled throughout the entire state of Wyoming eventually. Do you have an idea of the cost that you're estimating on that to provide this program throughout the state?
Ms. Brocious, if you know, or maybe if you remember kind of what the upfront fixed costs until it got to self-sustaining were.
Sure. So just to be clear, I'm here in the capacity of just informing on what and our success and or the program prior. And we're not necessarily advocating, I am not advocating, this, but I know Chairman Zwanitzer wanted me to kind of give an overview. Going backwards to that 2013 period, I believe the initial investment in 2013 was in about the $6 million range. So if you fast forward that, it depends on, kind of the scale and scope. And again, the number of patients that you were going to see, the additional The new building was probably another $5 million investment. So like I said, so this is the PACE is one program, and it is very heavy on the front end of the investment. There are some other options potentially where you could braid senior center and some existing infrastructure that would be in communities, so that the upfront cost could potentially be less, especially in the brick and mortar zone.
Follow up?
Yeah, thank you, Mr. Chairman. Okay, thanks for those numbers. That's helpful to understand. And then a kind of a question, and I don't know if we have the answer to this, but this sounds like a kind of a state-funded type of elderly care service. And it was one thing that was discussed was that it's a self-sufficient program with reliable revenue. Has that been the case in the example of Laramie County, where it was done in Laramie County? And then, I'm curious if this then is a self-sufficient program with reliable revenue. Do you know why private entities aren't necessarily jumping on board with this type of thing all over the place if they can make it profitable?
Ms. Brocious?
So a couple things. So the PACE, there are quite a lot of PACE programs in a lot of other states that are very successful. And so this was the one program that we had in Wyoming. To your question about it being self-sustaining, it's a learning curve to be a health plan. I do know that some of the other PACE programs in other states have come at it from different perspectives. Sometimes it's a health plan that develops it. Sometimes it was a hospital that developed it, and or a community piece. So there are very different ways that they've built that. The program is definitely not intended to be a huge money maker, because it is still, the intent is to use the funding in a way that creates better clinical outcomes using the funding that is already in place. So along those lines, but I do have to say that in Wyoming, at CRMC, the program was sufficient to support taking care of 143 patients. It had a staff of 45, was able to cover all of our overhead and salaries and benefits for that staff to take care of those folks.
And Ms. Brocious, in other states' PACE programs, many are for-profit companies who run them, who do derive a profit. Is that correct?
Yes. So there are some others. There is one other company on a statewide. Generally, most PACE organizations are nonprofits, but there is the CMS did change the regulations to allow for-profit organizations to run a PACE program, and there is a large organization that operates, for example, a huge chunk of the PACE programs in Colorado, New Mexico, California.
Representative Penn.
Thank you, Mr. Chairman. I'm still having a difficult time wrapping my head around how this actually works. You say that it's a 3-part program with CMS, the state, and the PACE program as the 3, if I understand correctly. You also mentioned that there's no out-of-pocket costs to the clients involved here. Where does the money come from? Because we know Medicaid doesn't pay very well. So I'm having a hard time understanding how this can even stay afloat, let alone make any kind of revenue whatsoever.
So let me back up just a little bit and talk about the funding. So if you think, the way Medicare, this is oversimplifying, right? But if you take what it would cost to take care of a Medicare patient for a year, all of those services, what CMS does is say, as essentially PACE is a managed care program. I'm going to give you that money upfront based on, I'm going to project this is how much it's going to cost a patient in Wyoming to take care of them if they go to the hospital or whatever, and you manage that care differently. And so they give you that capitated amount. So Medicare gives you that funding. And on the state side, the state where the Medicaid comes in, and or it would be a private pay, this piece would be a private pay piece. It's not very generally a private pay program. It does have the possibilities, but I'll set that aside. So what they do is they give them, if they were qualified, again, under that same criteria we talked about, they would qualify to be in a nursing home. They meet the financial criteria of having the resources. That payment that the state would make to put that patient into a nursing home would be what they would give the PACE program and say, I'm giving you this money up front, you manage it. If they end up going to the nursing home, you pay the nursing home. Otherwise, keep them safe at home and we will pay for that. So those two payments come in, and that's what the PACE program uses to pay for all of the care and all of the overhead for the program.
Follow up?
Thank you, Mr. Chairman. So do you have an estimate on what that upfront or what that yearly cost is? And then you said there was about a $5,000 or $5 million cost for a building. What was the building?
The PACE program requires, the PACE kind of infrastructure requires an adult day center and a clinic space, right? So you have, if you don't, so in the model that was in Cheyenne, for example, there was a clinic with a clinic space. That infrastructure to treat the patients was is the requirement of PACE. You can rent the space, you can build the space. It's up to the particular organization, the PACE organization. But that's the infrastructure cost.
Good.
Thank you, Mr. Chairman. And then did you have, like, what would that payment look like? What you say that they'll give you the annual cost to cover services for one patient upfront? How much is that?
You know, Ms. Brocious.
I don't remember. It gets really complicated because that's where you get the actuaries involved. And it's actually a calculation that CMS does that says this is our projection of what it would take. For example, if you have a Medicare patient who comes into the Medicare database and they have no experience, right? And so this is how any insurance, not just Medicare, but any insurance company does, and says, okay, if they're of this age bracket, it's traditional, and we see that this is kind of the utilization of hospitals and clinics, et cetera. And so there's a cost. But if that patient then is say a diabetic, right? A diabetic uses those services this much more. So it kind of layers. So there is a risk-based reimbursement process with Medicare that says if you're vanilla pudding, you get, I'm going to guess, this is not, I'm going to give you $1,200 a month to take care of that. Because in the span of a year, if they have one hospitalization, it generally costs this much. So Medicare it's a huge, complicated black box of calculations. Those are my words, right? And so it essentially creates a payment based on the risk of that patient having healthcare services. And so it pays the PACE program that amount of money in order to say, if something happens, this is our best guess of what we would pay for that same service. If that does that make sense?
Yep,
More
that's
sense?
helpful. Thank you.
And we still have the Department of Health here too, if we want to call them up. I know Franz has some of those numbers as well. Representative Ward, and then we'll go back to Representative Yen.
Thank you, Mr. Chairman. Just to clarify, so if this is 100% funded by Medicare and Medicaid, which are funded by taxpayers, I don't know how we can speak of it as being for profit, right? Because it's not, private business isn't generating a good or service that people are willing to pay for. We're taking government money to make a system that's mean, for-profit doesn't really apply to this kind of thing. Would you agree?
Oh, Ms. Broch, I mean, we have private prisons that rely on state money and they find ways to increase costs, but I know that's different, but it's some way of using federal and state dollars to have some entities for-profit corporations. And I think that's how Colorado's done it. Is that correct, Ms. Brochus?
Yeah, so it's really the business model. I mean, the idea, the concept here is that if you can manage the care better, then a patient manages their own care, that it should cost the trust funds less money, right? If you're giving more intensive care management and case management to wrap services around. So there was a conversation earlier about prior authorization. Okay, so let me give you an example. So if I have a PACE patient who comes in and says, and they, you know, they're not very physically active, they're diabetic, you know, they're diabetic and it's off the charts. They're, you know, so they're not stable. So with the PACE program, what that allows you to do is to take those two capitated, that funding stream and say, you know what, I think Susie needs an exercise plan. Medicare would not pay for a physical therapist to work with her unless she met A, B, and C criteria. The PACE program can pay attention to those rules or not, right? It can say, you know what, Susie needs this because I think if we can improve Susie's physical ability and stamina, she will then be able to monitor and manage her diabetes much better. And so you can use the funding to do it very differently. And that's the flexibility within the program. The concept then between the for-profit as an entity managing that, right, is that you would be able to do it for less than what Medicare or Medicaid could potentially, their risk of those same charges in the community if they went just out and received services from fee-for-service providers. Does that make a little bit better sense?
Yes, thank you.
Representative Yin, question?
Thank you, Mr. Chairman. Are there any statistics on the outcomes of the last 3 years for the members who were enrolled in PACE before it got shut down?
What kind of statistics on like outcomes?
Health outcomes generally,
Health outcomes?
yeah.
Ms. Brochus, if you know.
So I'm aware that I'm gonna lose it. There's a study that is currently being done on kind of a qualitative, interviewing PACE participants about their experience after PACE closed, which is more of like their experience. You'd have to look at pretty deep, and the problem with analyzing it is though this only 143 patients is a pretty small N. As far as doing a quantitative, that type of analysis, but you'd have to look at claims services. The challenge is also, it would be the Medicare piece that the state doesn't pay for, and then the Medicaid. So they're both, if you're gonna look at cost and the cost outcome, we'd have to look at both sides of that. Does that make sense?
Senator Hutchins.
But I'm just going to go ahead and ask you a question. With Medicare, that's money that comes out of our paychecks each month or week or whatever. And is there a way to decide who's paid into Medicare or not when they come into the PACE program? And by the way, the nurses in Cheyenne really enjoyed this program and would like to see it come back, just as a side note.
Yes.
Go ahead.
To your point of it being Medicare, so the patients, when they apply for the program, are already Medicare eligible, so they've met the Medicare trust fund requirements of the number of work hours and paid in, et cetera. So that's not something that the program has to deal with. You just have to verify their eligibility within the Medicare system.
Any other questions? Okay, not seeing you right now, Tracy. Thank you for being here with us. Certainly appreciate it.
Thank you. I'll hold on if you have other questions.
Please do. Department of Health, Mr. Grossman, welcome. Oh, go ahead. Yep. You can come up and sit and hang in, but go ahead, Representative Trujillo. Question for Ms. Brocious.
Thank you, Mr. Chair. Quick question. What happens when the PACE program gets defunded to the clients that are on there? And also, I'm doing a little Googling here, and it says that on part of the program, assessments to secure, like what if they rent, right? Or do they own a home? Right here, it says that the PACE program could be tied to their home and increasing the risk of foreclosure. Can you talk on that?
So actually that's not the PACE program. That is their eligibility under the Medicaid program. So that would be under the eligibility requirements that the state has set for the Medicaid eligibility that they're probably speaking about as far as their assets. Your question about owning versus renting, this program allows the patient to maintain. So for example, they get $800 in Social Security, and that's what they would pay their rent with, for example, right? So since the PACE program is getting the funding from their Medicare and Medicaid benefit to take care of them clinically, they keep their $800 in order to continue to pay their rent. The PACE program does not pay their rent, if that makes sense.
Yes, thank you.
Okay.
All right, welcome, Mr. Grossman. Mr. Fuchs. Thoughts on PACE or in any of those slides?
Good afternoon, Mr. Chairman, members of the committee. Lee Grossman, Wyoming State Medicaid agent. Director Johansson had to head back to Cheyenne, so I hope you'll accept what myself and Mr. Fuchs can offer up for the rest of the afternoon. Just to be somewhat brief, Ms. Brocious did a great job in terms of introducing PACE to you all in a summary. But if you look at our omnibus slides number 33 and 34, we'll give you just a little bit more background there from the state agency perspective. Some citations there in terms of the authorizing statute and the timeline from our perspective. And I would really just skip ahead in particular to towards the bottom of slide 34. I don't need to tell you all the general shape of the state budget towards the latter half of 2020, and there were obviously a host of very difficult budget decisions that the state needed to make. And one of those was the elimination of the PACE program at that time. There have been a lot of questions in terms of funding, so wanted to provide just a little bit of information. So when this program was cut, that was $3.6 million for the biennium state general fund. So in terms of what the price tag was to the state budget, I wanted to provide that to you all. Also heard some questions about, well, where did these folks go once the PACE program closed down? And according to the data that we had, we tried to track those folks that may move to a different service setting. 86% of the folks who were receiving PACE services at the time it was ending received services on our Medicaid Home and Community-Based Waiver Program, the Community Choices Waiver Program, and 14% went to receive services at a local nursing facility. So just again, hopefully some additional background from, again, our experience on the state agency side of things. With that, I'll turn it over to my colleague, Franz Fuchs here.
Thanks. Good afternoon, Mr. Chair, members of the committee. Franz Fuchs, Policy Analyst, Department of Health. Just continuing where Lee left off on slide 35. Recently, as you know, you all added a footnote to our budget that appropriates $20,000 to conduct a study of a review of the PACE program. So the footnote states that the study, quote, shall review the possibility of reinstituting the program throughout Wyoming, considering for-profit and nonprofit options and potential cost savings. So we've taken that. You can see on next slide 36, we released the RFP for that study at the end of March. We've answered about 6 questions on that. since the questions were closed. RFPs are due on the 5th, and we'll see what we get. We would anticipate work beginning in June, should we award this RFP. And slide 37 kind of talks about a background, our proposed background that we put in the RFP for the contractor. Essentially provide background on the program, look at a cost effectiveness analysis of the program, looking at the realized counterfactual of the settings that the people went into after PACE ended up closing, and using that data to develop an actuarially fair methodology pursuant to the statute that could be used to come up with a rate that would be applicable for future PACE programs that would meet that intent. And then we would basically look at the overview of PACE delivery requirements. There's quite extensive, as has been testified to by Ms. Brocious. And we'd look at try to get a list of nonprofit and for-profit entities that might be capable of doing that. And then we'd take the rate that was developed and say, hey, are you, would this make sense for you? Would any be interested in giving this rate? So, because I think there's a difference between, are you interested in giving it unlimited money and are you interested under this budget constraint? I think they're two separate questions that need to be answered. So with that, if there are no bids, then we will do the study ourselves. And with that, happy to talk to any questions.
Jump on in.
Thank you, Mr. Chairman. So the fact that we shut this down saved us approximately 3 million or more, correct? Is that what you said?
Mr. Chairman, Representative Ward, the program cost us 3.6 million general fund plus 3.6 million of federal funds each biennium. But there's, when we move people to new settings, they also cost money in those settings. So the savings were actually closer to $700,000 of general fund per year.
Follow up? Thank you, Mr. Chairman. So still, it was $700,000 less than if these elderly patients were in other programs. So this program, as administered, is still more expensive than other programs you mentioned in your slides.
Mr. Chairman, Representative Ward, that was our experience.
Would that potentially be due to the fact that people lived longer than expected in this program and didn't meet the rate of death that most nursing home patients meet on average? Was that part of the reason it cost more, that people weren't necessarily passing away on the otherwise average because they had a more inclusive program?
Mr. Chairman, we can't really speak to the mortality or outcomes of the program. We haven't studied that in depth. Because it is a managed care framework, there's a limit to the kind of data that we get from that program, because we pay the premium, right? We don't see the claims data. We don't see any of the detail from the experience of those members. So unfortunately, there may be, we'll see what we can do, of course, but if requested, but we haven't done the analysis and it would be kind of difficult based on that lack of data.
Representative Penn, we'll go to Senator Hutchings.
Thank you, Mr. Chairman. What did the $3.6 million or six, depending on how you look, what did that actually go toward? Did that go toward specific services? Is that the state's share of things? Because initially it was said that there is an upfront cost. So does that allotted general fund per biennium, is that, I mean, that's in perpetuity. So what's the difference between upfront costs and then these continued costs?
Mr. Fuchs, if you know.
Mr. Chairman, Representative Penn, I think the way to think about the state's perspective is that we are paying essentially an insurance premium. So that $3.6 million of general fund matched with $3.6 million federal was paying for premiums for each of those members. So the startup cost is really on the, if you were thinking about like an insurance company, it'd be their business on their costs, and how they finance the whole startup and their operating costs are different than what the state's perspective is, because they are taking the risk for all those clients. So from our perspective, what it pays for is a premium, right? That we pay approximately $2,250 PMPM per member per month to PACE, and they provided those services. And how they spent that premium was up to them.
And that was the number kind of asked earlier. On average, it was about $2,250 per month among those 140 clients, and you divide them all out. Okay, Representative Penn.
Thank you, Mr. Chairman. And so that 3.6 million went to cover premiums for because the initial study was for 64 patients, correct? And then she was mentioning how we have 135,000 people that would potentially be eligible for this. So how does that calculation work out?
Mr. Chairman, Representative Penn, that 3.6 million figure comes from around 2020, when enrollment was peaking around 145 people. So when enrollment was lower at 64, obviously we were paying less, right? We're probably in the neighborhood of $1.5 to $2 million. And that, of course, because we're paying a flat premium per person, as the enrollment grew, our outlays grew. The 134,000 figure, I believe, is the entire demographic of people over 65. And so the vast majority of people wouldn't necessarily need nursing home care right now, may not be eligible for Medicare, Medicaid. So the number that actually might qualify for PACE, a PACE type program, would be significantly smaller than that.
Thank you, Mr. Chairman. At one point, they said this is a capped program. Do we have an estimate on what the cap would be? How many we would allow into this program?
I think they said it was perpetuate funding, maybe. Well, they said 64 was their projection, and they went above that, but I think that was on how they do funding. Mr. Grossman, is that correct?
Yeah, Mr. Chairman, Representative Penn, so that's in reference to the capitated payment just being essentially a cap on the payment per member per month, not necessarily a cap on the program enrollment.
So would anybody be eligible that qualifies for both Medicaid and Medicare? All of those elderly citizens in our state would be eligible for this program?
With Mr. Chairman, Representative Penn, Mr. Fuchs and I are looking at each other and fighting over the mic, but to an extent, that would be one of the base requirements. You also heard in Ms. Brose's presentation that there's other factors such as meeting nursing home level of care. So essentially meeting that medical necessity that anyone that at least is covered through Wyoming Medicaid would need to meet to get nursing home or Medicaid HCBS coverage. So it's not just the Medicare, Medicaid piece. Again, there's that medical necessity component as well. Plus of course, the condition that's inherently limited in terms of provider capacity, right? So in this case, was CRMC able to take on more folks?
Yeah, no, thank you, unless she has more. I think if she has more, go for it.
Just one request, if we're going to continue with this in future meetings, if we could just maybe have a number of an estimate on how many people would actually be enrolled in this, I would appreciate that.
And I think there's certainly, you have to have a certain economy of scale, right? You can't just have to be a town of 15 or 20,000. I would think to have the providers necessary and that geographic area, but if you could do some type of analysis, or whoever takes the contract probably could do that. But if it's not them, if you guys would do that, that'd be great.
And
go ahead,
Mr. Chairman, if I may, we currently have about approximately 4,000 people enrolled in Medicaid long-term care programs, whether that's the community choice waiver or nursing home. So that's kind of the base of population by which that would be eligible for PACE. If a PACE program stood up somewhere, it would draw from that population.
And we could project that over the next 10 years with our population demographics of how many people might be eligible. Go ahead.
And if I may add to my colleague's answer, Mr. Chairman, Representative Penn, I think that question is also a core part of the study and the direction as we understand it, to really dive into that, again, depending on the outcomes of this RFP with that consultant in terms of really getting you some in-depth information there. So.
Senator Hutchings.
Thank you. Limited knowledge, but just want to understand. I keep hearing Medicaid, Medicare, like I say, the taxpayers paid for that. And I'm assuming that insurance has, that money is set aside for things like this. Medicaid comes out of wherever. So I'm wondering the patients that have put into Medicare, is that the federal funding? Is that part of that coming out of Medicare from the federal side? Or is it both coming out of the federal side? Does that make sense to you? Because I'm trying to figure out how you guys are differentiating these two, Medicaid, Medicare, who's paying for what?
Right. Go ahead. Mr. Chairman, Senator Hutchings, we can probably follow up on that because my understanding is there were sort of primarily Medicare premiums that were going to PACE, and I'm not sure we have much visibility on that.
Gotcha.
And then we had primarily Medicaid premiums that we paid to PACE, which is that 3.6 million general fund, 3.6 million federal. So we'd have to, I think, go back and try to figure out the breakdown of how many were Medicare only maybe versus Medicare, Medicaid. But both come from federal outlays. As you know, just looking at old slide deck, Medicare funding is 36% of it comes from payroll taxes, as you mentioned, the FICA that you see on your paycheck every day or every month. 15% comes from premiums that are paid by beneficiaries. 43% of Medicare is funded from federal general revenues, and 6% of Medicare comes from state payments. So
Gotcha.
Medicaid is coming from federal general revenues, 100% of it, the federal share is. For Medicare, it's 43% is coming from that. So the funding sources are similar. ultimately.
Fascinating. Thank you.
Other questions for the department? Representative Chadwick.
Thank you, Mr. Chairman. So I have to ask this. So how is the quality of care compared to, with the program, compared to not having the program? And how do you measure that?
Mr. Chairman, Representative Chadwick, that's a very good question. And I think the unfortunate and unsatisfying response is we don't really have a good ability to measure that. We can look at things, most of our data comes from claims data. So we can see, for example, the rate of ED emergency department visits per 1,000 member months. So that's a rough measure of how often people are going to the emergency room. But that's only a proxy for quality, right? We don't have the administrative overhead to survey people on a regular basis on how satisfied are you with your care. Mr. Grossman may be able to speak to, we may have done like limited surveys of recipients, but we don't do that as an ongoing process.
Mr. Chairman, Representative Chadwick, really the only thing I would add to that, Mr. Fuchs hit the nail on the head in terms of some of the limitations. Anecdotally speaking, though, we at the department would also be the first to add that the responses that we would hear from community members was very positive in regards to this program. Perhaps that's something you all have heard in Laramie County as well. But in terms of some of the more clinical-based outcomes, we heard questions on mortality, for example, earlier, and those types of things. Unfortunately, we don't have that data, especially if we're talking about a before and after snapshot. But again, in terms of just overall and general satisfaction, certainly seem to be quite high with this program from our perspective.
Okay, another one, Senator Hutchings. And let me take that. So that was a budget footnote that the co-chairman and I both put in the executive process when the governor line itemed the budget in certain places. That wording changed a bit. And so then there's some question on the 20,000, if you are going to find an RFP, if somebody really will take on the project for 20,000, because there's some belief it might not be high enough, why it may be turned over to you, but you are fully equipped and ready to handle it if you don't find a qualified respondent.
And Mr. Chairman, I would just add that we recognize that the governor vetoed that outside language, but we know it's your intent that the legislature probably prefer an outside study, so we are going through the RFP process for that reason.
I appreciate that. That was, my language said outside of the department, but I fully trust, as you can imagine, committee, this was a very traumatic experience in my committee. Most of the CNAs and the nurses who worked there said it was better than any nursing home they'd worked in. People were living longer, people were happy in the community. And many of those people within a year, a third or so were no longer with us, which is kind of natural progression, right, in that stages, but it was pretty traumatic. And so it was one of those budget cut things that when we asked all the agencies to do horrific cuts across the board, this was a big area of general fund that I shouldn't say it was easier to cut than others, but with all the programs the department had, you were cutting the social safety net everywhere and impacted a lot of people we impacted people very negatively, and this is what they offered up as in their cuts. Seeing no further questions, all right, get you off the hot seat, and maybe if you would send us an email, at least the committee or the co-chairs, when you offer the RFP, or if nobody comes forward and let us know you're doing it, I would be appreciative. Mr. Grossman.
Mr. Chairman, thank you. We'll be sure to do that. And if I could just add one last sentiment, I understand you've heard a lot of, I don't know, or that's some information we have to take a deeper dive into. And so please know that we're noting this, especially the fact that we're at the very early stages in terms of beginning that study, that these are the types of things that we can take a deeper dive. So that way, once we produce that for the committee, that hopefully you'll have more of your questions answered. So just thank you for your patience as we're working forward through that process.
Mr. Chairman, thank you. Mr. Grossman, Mr. Fuchs, do you know, I mean, maybe you mentioned this and I just missed it, when we will end up getting the results of that study in this committee?
With the RFP timeline, did you put on that it needed to be in before our September meeting to present to this committee?
Mr. Chairman, Representative Yin, I'm not recalling a specific deadline. We will certainly try to get that to you as soon as possible. The RFP is really preliminary because we get those responses, we see what we get when they actually write the contract based on that. So once we get into the contract writing process, if you all have a preference for a September deadline or a November deadline or whatever, we're happy to try to accommodate that. Recognizing that we may have to truncate the amount of studying we can do depending on the time.
Thank you. Mr. Franz, can you also add those 6 questions you asked? Thank you.
As part of the research and the study, throw those in? Okay. All right. Ms. Sherrard is online joining us. I don't know, there's other public comment on PACE. There is, so if you guys would come forward, occupy some seats, but we'll turn it over to Phyllis on Zoom. Floor is yours, Ms. Sherrard.
Sherrard.
There you are. Welcome.
Good afternoon. I know it's been a long one. I'm Phyllis Sherrard, and I am the Senior Legislative Consultant for Cheyenne Regional, and was asked to make a couple of comments this afternoon from Cheyenne Regional's perspective, and I'm delighted to do that. I think I was asked because before I retired from full-time employment at Cheyenne Regional, I was part of the original team that stood up the PACE program. But Cheyenne Regional wants to primarily make 2 points here. The first is, as you have heard over many years, as Senator Hutchings alluded to, as well. This was a much beloved program throughout Laramie County. It was beloved by the patients. It was beloved by the family members who were able to keep their seniors at home. And it was beloved by our staff and employees and the providers because they knew that they were making a difference in the lives of these PACE participants. Cheyenne Regional is committed to providing information in response to questions from whatever contractor the health department ends up with or chooses to do themselves to conduct the RFP. There's certainly information about reported health outcomes and what our experience was with the program. And at the time of its closing, because it was so much beloved, there's a lot of that feeling still lingering in the community, and Cheyenne Regional wants to be able to provide whatever data we have or had at the time that will advance the RFP. We certainly will not respond to the RFP to conduct it, but to answer any questions or provide information that's still available to us, we're going to stand ready to do. The other thing that I want to underscore And this is come up and it's obvious in some of your questions. This three-part partnership is extraordinarily important to whether any organization would choose to go back into providing PACE services. So assurances to any of your future PACE providers that for instance, that the health department would continue to fund as long as CMS is recognizing and funding the program. Those kinds of assurances will be very important. Cheyenne Regional operated this program at a break even. We certainly made no profit from this program and invested significantly, particularly when we moved to the second location, which was much larger and purchased and remodeled for the specific purpose of being able to provide those services required by a PACE provider. So I just have been asked to illustrate those two things. Whatever information we still have to advance the conversation, we stand ready to participate and provide that information to the contractor for the RFP. As you consider whether you're going to advance back into this program, remember the importance of the three-way partnership and the very real need to provide assurances to future PACE providers that they're not going to be in a position where their investments would be subject to the state's budget woes. And we all understand that, and there was obviously no ill intention in shutting down the PACE program, but because it is a novel program, a lot of your questions are coming from the fact that it is a managed care program that we don't have much experience with. The outcomes and the cost effectiveness comes because you're providing well-coordinated, well-communicated, and well-managed care across a very vulnerable population, and that will continue to be true. But let the RFP and the questions guide the decisions as you look forward, whether or not this is the program to stand up again. And as I said, remember the importance of continuing the three-way partnership without being at the mercy of year-to-year budget cut. That's critical when you are a not-for-profit private provider engaged in partnering and providing service to a very vulnerable population. And with that, I thank you for your time and for listening to this testimony.
Questions, Ms. Sherrard? Not seeing any. Thank you very much for being here, Phyllis.
You're welcome. Thank you.
We're now up to the 11:30 portion of our program today. Welcome, Ms. Shikic. Can I start with you? And
thank you, Mr. Chairman. Mary Lynn Shikic. I'm representing Wyoming Senior Centers today. And I'm about to expire because I'm almost brain dead, so I can only imagine that you all are about in that same place. We wanted to enter this conversation recognizing that the senior centers in the state might be in a position to provide some of the services and already from a community standpoint provide many of those services. And so we hope that the committee over the next two meetings, including this one, will help maybe consider this not as a binary decision, either you do PACE or you don't do PACE, but how can we help address in a further capacity the silver tsunami that's here with us and with really the primary providers in all the communities and communities that want a new senior center or need a senior center can serve in that role. So we felt we'd be remiss if we didn't enter the conversation today. So thank you for your time.
we'll just go down the line. Welcome.
Welcome. Well, thank you for having us. My name is Carmen Rideout. I'm the Executive Director of the Senior Center in Sheridan, and I've been there for 23 years. I appreciate this opportunity, and we were excited to address this topic of the growing aging population and the need to invest in community services, because that's what we do. Today, 39 senior centers serving older adults throughout the state of Wyoming, and our purpose is to help people stay well and active and living at home. We applaud and support a closer look and investment in new and innovative service options and funding models to provide care for our growing senior population. It is needed. We are impressed that a critical piece of the PACE program looks at not only the medical and healthcare needs, but combining those with the social needs of older people. And that's what senior centers are all about. These social supports and preventative services described in the PACE program are what senior centers have been doing in many cases for the past 50 years. Senior centers are part of the social infrastructure of our communities. And I like to describe it as a three-prong approach. One, we provide information and education to help people help themselves and be as self-sufficient as possible. We provide information and education on benefits and services and community resources, on health issues, on safety, how to stay safe. And most importantly, we're finding how to get ahead of this in planning. So working with younger people even, and how to plan, how to save money, how to think about what their care might look like. The second approach is providing opportunities for health and wellness. So for people to stay healthy and well, to delay chronic health conditions and hospitalizations. We do this through our meals program, all the exercise classes and social activities at our senior centers, and by providing many, many volunteer opportunities for people to get engaged. We believe older people are going to be needing to take care of older people, and having those opportunities is important. Then the third and final approach is providing direct services that help people who have physical and/or cognitive limitations. And we provide these services, direct services, to prevent nursing home placement. So the grant that you all are familiar with, the Wyoming Home Services, is a big part of that approach, providing personal care and housekeeping, shopping, laundry, all those kinds of things make a difference. We provide care coordination and case management, home delivered meals. We have a pretty robust transportation system, door-to-door assisted transportation funded through WYDOT. A number of our senior centers have adult daycare programs, and we also are supporting family caregivers. These services are funded in numerous ways, and each community is a little unique, but we receive federal funding through the Older Americans Act. We are a provider of the Community Choice Waiver that provides services to people eligible for Medicaid. Some of us have contracts with the VA hospitals. There's state funding, the Wyoming Home Services Grant, the Wyoming Senior Services Board, cities, counties, private donations, philanthropic foundations all support our programs in our various communities. And then the people that utilize our services also contribute with income-based sliding fees and voluntary contributions. We work closely and collaborate with local community partners, including primary care providers, community health clinics, community hospitals, mental health clinics, senior housing facilities, and the Department of Family Services. Working together in our local communities and across the state is very familiar to us and something we know how to do. We appreciate and are grateful for the support and collaboration we have with the Wyoming Department of Health. And our message today is that we are eager and willing to be part of the solution and to continue to work together with these organizations and the Wyoming Department of Health as we look at new and innovative approaches to serve our senior citizens across the state. Thank you.
Thank you. Questions, Ms. Rideout? Not seeing yet. We'll keep going.
Next.
Welcome.
Good afternoon. Thank you. Thank you for having us, Mr. Chairman, and the members of the committee. I am Ann Rossi. I'm the director of the Campbell County Senior Center, and I'm also the president of the Wyoming Association Senior Project Directors. I have had the pleasure of working with the seniors of Campbell County for over 17 years. As a senior center director, we see the need that our senior population have. Senior centers are the support system and for the seniors in so many ways as they are aging in place. Every county has a senior center. Some have more than one. If you haven't been in a senior center, you are missing out. We would like to extend an invitation to you to go ahead and visit your local senior center. Get in there and see what it's all about. Senior centers, they understand the importance of what the seniors' needs are. We get what socialization is all about, but getting into the center, it's more than that. It's about feeling the energy. It's seeing the smiles on their faces. It's about the laughter. It is so different when you get inside the building than observing from outside. These centers are the heartbeat to many senior citizens in our state and also their lifeline. We are here to be a partner. We want to be included in the process. We want to be a part of the policies. And as we're moving forward from today and from days hereafter. So thank you for having us here today.
Thank you, Ms. Rossi. See no questions yet. Go ahead.
I'm sorry.
So my name is Linda Cockett, and I just want to thank you, Chairman and committee members, for having us here. I'm the Executive Director of the Goshen County Senior Friendship Center. I represent seniors in 5 different communities throughout our county. And many of them have been farmers and ranchers all of their lives and do not have significant retirement savings. Many live only on their Social Security benefits or possibly a small retirement from a part-time job. The Wyoming Home Services program that many of us currently administer help meet the needs of those seniors who are in the gap. They don't qualify for Medicaid, but they also don't have considerable retirement savings that would allow them to pay for private care. Programs like Wyoming Home Services or PACE help seniors stay in their homes and remain active members of their community. They pay taxes, support local businesses, and become involved in issues that affect those communities. We already have many partnerships both in our counties and across the state. Senior centers are established organizations in each county where seniors know that they can receive quality services and trustworthy information for a variety of topics. Senior center directors are experts on the needs of seniors, and we have those structures in place to provide various programs. We would ask that this committee include senior center directors as we work together to provide programs that benefit seniors across the state. We do have some concerns about the PACE program, mainly the cost implications and the lack of resources in many of our communities to provide those wraparound services. But Wyoming Home Service providers are willing to use PACE as a model and use elements of it that could be tailored to each community. We feel we owe it to the citizens who have given so much to our great community over their lifespan to continue to provide services for them. So thank you.
Thank you. Any questions for anyone on the is it Representative Trujillo, and then we'll go to Senator Dockstader.
Thank you, Mr. Chair. I just want to say thank you, ladies. The senior centers are very beneficial to our communities, and I greatly appreciate everything you ladies said. Thank you.
Senator Dockstader.
Thank you, Mr. Chairman. I've heard you speak from different parts of the state now. If I go into my senior centers, there's no place to sit down. Are you finding the same thing in your senior centers? There's no room. I got one situation where they have a senior center town hall, and they use the town hall as for seating in addition to the center, everything in the hallways, and even sneak into some of the side offices for the town hall. And summer's coming sometime, but when it arrives, they'll be outside on patio tables because there's nothing left inside. Are you seeing that?
Yes, Mr. Chairman, I'm happy to let them speak individually, but it is an explosion that we're seeing throughout the senior centers, and the combination of a large growing number of people who come to the center and who need services, combined with what we're all experiencing with the inflationary costs. We're finding certain programs, such as Wyoming Home Services, that we're not able to serve as many clients as we have historically. But absolutely, it is, that's one of the main reasons we wanted to be here today, is that I think we are currently a solution, but we see a growing problem. We want to be a part of that solution as well.
Follow up, Mr. Chairman. So I saw some stats up here on the screen earlier today that we're going to be at, what is it, 2030? And the numbers are going to be staggering for seniors. And what's our plan to address that? What's our situation? How do we do this? I see the senior center as not only a place for those on fixed incomes to get a decent meal, but they're just simply looking for sociality in their life. That is their sociality for a given day or a week. So
we agree with you, Mr. Chairman, and we applaud you. We think that our growing future for the senior centers in our rural, very frontier state, in so many of our communities, almost all of them, for many seniors, that is where they go for the day. And we see a growing need, and perhaps some of those services that we do in certain respects. And I do want to say, similar to what you heard yesterday with the EMS programs, the senior centers vary dramatically through across the state, and it's so dependent on the resources. I think you all remember during this past session, there was legislation that you passed related to a particular senior center services district in Converse County who benefits from a fortunate at 2 mills where they have significant dollars. Well, that is a contrast to the senior service district up in the Crook County area where they hope to get somewhere around $200,000 a year. And they do have the districts where some have 1% taxes from their community, some get county, for instance, in Carbon County, they get funding from their county. It's very different, similar to the EMS districts. But we see a future opportunity, and we would like in the next couple of meetings to talk about where we see some potential need. They would speak, you speak much better to it than I do, but none of the care coordination or any of those kinds of services are compensated services. And it's, as was mentioned here, you see the need firsthand there where somebody's not getting basic activities of daily living taken care of. They have no food at home or things of that nature. So, we are necessarily the community decision maker on some of those areas. And we'd like to continue to be that and grow in each of those areas where it makes sense for your communities. And we recognize the value of the PACE program, but we all heard today how difficult it is to even consider that concept in a formalized manner. But perhaps we can take some pieces from it, from that study and other things, and see how we could craft community decisions with the support of the state legislature. I hope that doesn't sound too pie in the sky, but we really hope that we can create some potential opportunities going forward.
Any specifics you'd like to offer now? We're happy to probably, you got us our attention. Is there anything you would like us to pursue for our next meeting? Some research, talk about have the community grants, up on the table. If they're not being funded appropriately, we can certainly get Mr. Grossman to come back and kind of give us an overview.
Well, thank you, Mr. Chairman. So you do have a state appropriation for the Wyoming Home Services Program, and it will be coming up again in this budget session. And I wonder if you'd be willing to consider possibilities of some, inflationary costs, but that's a simple sort of thing. I think if the LSO would be amenable to looking at some of the programs that senior centers around the country may have where they do care coordination, things of that nature. We, if I understand correctly, are the only state that doesn't have what they call area agencies on aging. So it's federal dollars. So in the larger states, they have these agencies throughout the communities that work with the senior centers and others. But given our low population, our so-called area agency is actually housed inside the Department of Health, which historically has made sense, and it may continue to make sense. We're just trying to help craft some solutions that might involve better care inside the communities.
Committee, any problems if we direct LSO to do some research on area, what were they called?
Area agencies on aging, but more specifically, the kinds of expanded services that senior centers provide throughout the country.
I don't know if I need a motion. If it's okay, we'll just direct Ms. Shippen, if you could get us some research, a couple pages, and maybe we can do a small presentation at our next committee meeting or the one in Saratoga on if it's a potential for Wyoming, and I'm sure you could work with the Department of Health as well. Representative Hornock.
Thank you, Mr. Chairman. You may be able to answer my question. I'm not sure if this is a motion or just a comment generally. Well, there's a current RFP on the out on the street, and I'd like to include within that study a connection or the coordination of the possibility of connecting these services with our existing senior center programs throughout the state. I'd like that included within the study that's conducted, not just the specific PACE program and what that would be, but if there is a possibility of making a connection with those two and what that would look like, any options for what that would look like. So I'm not sure if that's a motion or if we can just ask the department to include that, do an amendment on that RFP or what
So
that
I think
looks like.
in the budget language, it might be somewhat specific and your RFP is already out on the street, but certainly depending on if there's multiple responses or one response when you're drafting the contract. Any way you can incorporate that, Mr. Fuchs and Mr. Grossman, I'm sure you will. And if you get the contract, you would add a section. I think it's about as good as we're going to do since RFP is already out there. While I have the three of you here, anything else you'd like us to think about, research, waivers, grants? In Laramie County, right, we actually had a 6-penny thing on the ballot to redo our whole senior center. And I'm at mine every week. And I always get the form of, do you qualify under any things, my age, my income? And I'm like, no, I'm young and healthy, just here to play bridge. But everybody else has to they check in every time they're there, and funding is dependent on, and so I'd assume with more people, you are getting more funding. That's my question. We track ours very meticulously of every person who walks in for anything. This is how often the center is being used, and then they use those metrics for funding. Are you able to do that in your communities?
Mr. Chairman, committee members, yes, we are counting and measuring the number of people that we're serving. We're also counting and monitoring a waiting list for Wyoming Home Services and our Help at Home programs. That is a reality for us. Last month, we signed up 35 new people, brand new seniors to our center. Right now, we're in Sheridan serving over 3,000 people. The metrics are there. However, the funding has been pretty flat as far as the Older Americans Act and the state funding for years. So that is our challenge. The other challenges are, as I mentioned, our senior centers a lot of them are celebrating 50 years of service. So our facilities are either very crowded or in need of some repair and maintenance, and those are funds that we don't have access to readily as well. So we're at a turning point right now to figure out how to make things happen and serve the greater number of people.
I'm sure Mr. Grossman is listening when I tell him in Evanston meeting, we're probably going to ask about the Wyoming Home Services, grants, numbers, utilizations, funding levels. We're not appropriations, but we can act like it sometimes. So if you commit that to memory, that it's probably going to be on the agenda in June. Anything else? Senator Hutchings.
Thank you, Mr. Chair. As you spoke, you brought up some things that I thought maybe I can give you some ideas on how to help. I thank you for bringing to our attention, along with the PACE program, the debt we owe to our seniors. We tend to focus on the youth or in programs, and we forget about those who paid a price to make our country what it is today. And I was wondering if maybe you can look into some of the scouting organizations in your city, Trail Life, where they have or Heritage Girls, where they have young men and young women. When I was in the military, the top 3 would go out, in rank, would go out and do community service, where we would buy paint and hammers, nails, and come out and fix up homes for people. So maybe you can reach out to the community and say, hey, who wants to come out on a Saturday and help us clean up the center, or fix shingles, or clean glasses? So just a thought, but thank you.
Yep. Representative, or did you have any comments? Okay, Representative Yen?
Mr. Chairman, thank you. So that slide on the population by age group where our Economic Analysis Division predicted that the aging population is going to explode. I mean, basically to follow up on what Senator Dockstader had said, does this concern you on what that will look like? Because all the other demographics are also going to shrink at the same time, on what being able to recruit to be able to service this population looks like, as well as, I think it's very concerning from the legislative side, because we're gonna have to be able to budget to be able to service that population. But I assume that without a population to work that, I mean, even the cost of just hiring workers or getting them into the state is going to also dramatically rise. Do you predict that that will happen? What are there policies that we should do? Should we start also encouraging young people to move to the state?
So
Any
Representative-
thoughts on Representative Yen's comments?
Yeah, Representative Zwaneter and Representative Yin, we are already seeing that. We're having a huge hiring flatline where we cannot get employees to even apply, let alone hire them and have them, pass their drug test and their background check and stay long enough to go through our onboarding process. So that is a huge issue. We're also seeing that that employees have this rosy picture of what it's like to work with seniors and don't always live in the reality of, seniors sometimes are in pain, they're lonely. And so trying to onboard employees to that reality can take longer than if you're hiring somebody at a fast food restaurant, for example. And so we are seeing those crunches, we've been seeing them for the last couple of years.
Okay. Representative Trujillo.
Thank you, Mr. Chair. What would you ladies feel like having the senior center as like the focal point? You said you work with other nonprofits and you also try to keep people in their homes. And well, with the PACE program, you need to sell your home to qualify for it. So does that feel like too much of responsibility?
I think hearing the presentation today to take on the full concept of a PACE program would be too much for the senior centers in the state. We would hope to look at some of the aspects of the PACE program that are outside what are currently being done by the senior centers and maybe help be a part of that solution without, we do understand that in some of the larger metropolitan areas in the country that maybe some of the senior centers are part of a PACE program. But from a population perspective, I think it would be very difficult for the senior centers in Wyoming to take on that kind of responsibility.
All right. Well, thank you all for waiting for the day and hope you've enjoyed Casper while you've been here. Always a pleasure seeing you and certainly welcome to come to either of our future meetings, Evanston or Saratoga. Thank you. And I don't think there's anyone else online on this topic, but let me just check. Seeing none. Next up is agency updates. Whichever agency steps forward first gets to be on the road first. All right.
They run.
Mama raised no fool.
Commissioner Rude, welcome.
I am the sprinter, Jeff Rude, Commissioner of Insurance. We were asked to give a brief overview, and it will be brief. Our department has authorized 27 people. It was 26, but with PBM legislation, it is now 27. It has been the position and the classification has been approved by HR. It should be posted soon. So we regulate all aspects of insurance, but we also deal with some things that you wouldn't really classically think are insurance related. We register motor clubs. We license service contract providers for extended warranties on appliances and cars. We license pre-need funeral homes. And then we also do all of the more of the traditional areas with agents, brokers, and adjusters. I really break down what we do into 5 areas. We license insurance companies and we license agents. And there's roughly 1,150 insurers who sell insurance in the state. They're authorized to sell to Wyoming residents. Some of them have a big footprint, some have a very small footprint. We license approximately 2,800 Wyoming insurance agents. And then we also license 185,000 non-residents agents, which is an astronomical number when you do the ratios. We collect licensing fees and we end up depositing about $21 million a year into the general fund. The second area is we collect taxes on premiums that are paid to insurers, and that raises another about 26 million, which goes into the general fund. The exception is the premiums that are paid on fire tax, or the tax on the fire premiums actually go to the fireman's pension fund. So it's 100%, we just make a transfer each year. The third thing is we examine all domestic insurers to ensure financial solvency. We monitor this quarterly, but if there's ever a concern looking at the risk that they're taking on, we get involved and we try to turn the company around. If in fact it goes south and there's a liquidation, we're in charge of the liquidation. That happened about 5 years ago with the health insurer. It took almost 5 years to close that liquidation out. It is a painful, long process. Next, we handle consumer questions and complaints against insurers, and we assist consumers. And this is where if you have questions by your constituents, not just on health matters, but on any insurance matter, a hail claim, car insurance rates, whatever, send them our way. Just shoot me an email, tell me who to contact, and we'll get our consumer person in touch with them, and we can help you out with any questions they may have of you. Lastly, we review insurance contracts. Every single policy that is sold to a Wyoming resident has gone through our office. We ensure that it complies with state law, and then we ensure that any regulations that we have. And the last thing I'll say is we work closely with the National Association of Insurance Commissioners. These are the commissioners of all the other states. We work on national issues together. So if there's a large insurance company that has complaints from consumers, say out of Illinois, we band together. We can take action against that company. And if there's a fine, and there are plenty of fines that go out to some of these companies, we get a pro rata share based on the number of Wyomingites that have that policy. So with that, I'll stand for questions.
No legislation this year. Oh, that's my corporations. Never mind. Sorry, every year in corporations, the insurance commissioner always had 1 or 2 model NAIC bills he'd bring forward, but nothing for Labor Health
Mr.
Committee.
Chairman, not this year, maybe next year, we're looking.
Any questions? We'll start with Representative Hornock and go to Senator Hutchins.
Thank you, Mr. Chairman. Do you deal with all types of insurance contracts, individual vehicle company insurance, liability insurance, just all across the board with business and personal?
Mr. Chairman, Representative Hornacek, yes, we do. There's certain, we don't get involved, as you heard today, with certain aspects of the health market. I mean, we don't have any real authority over the VA or TRICARE, things like that. But when you start looking at the traditional stuff, your home insurance, your car insurance, your mortgage insurance, those things, those policies, and we'll look at this base policy, and then we look at all of the amendments. And then if there's new base policies that come out the next year, we look at those. If there's new amendments, we look at those.
Thank you, Mr. Chair. Director Rood, you mentioned a lot of things that you cover in your office. Is it possible to get that list? I don't see it in our package, and I would love to have that.
Mr. Chairman, Senator, I can send that out. It's on our homepage. I'll pull it out and I'll send it to you.
Excellent.
Other questions on insurance? Corporations Committee is an amazing time, I want y'all to know. But labor, health, and, well, health insurance is good too. Thanks, Commissioner. Enjoy your weekend. Ms. Sessions Cooley, or Director Cooley, you want to be next? You don't have to, I mean,
Slow down.
Mr. Chairman, members of the committee, Robin Cooley, Director of Department of Workforce Services. Happy to be here today. I did provide you with a lot of information in a PowerPoint presentation. What I'd like to do instead of just walking through that really is talk about, you indicated legislation elsewhere. I'd just like to let you know that the Joint Appropriation Committee will be considering unemployment insurance and workers' compensation insurance this year. I think taking a deep dive into both the funds as well as the taxes that individual businesses are paying for those particular coverages. I'd also like to talk to you just real briefly. We've got a lot of information in, like I said, in the PowerPoint, talking to you about employment data. Again, that's something that our agency does. We've got an office here in Casper, Research and Planning, provides a lot of employment data. If you ever need anything from them, please reach out. They're an incredible group of individuals and can provide all kinds of really good, valuable data for you around employment. And again, in here, we've got a lot of good information. One thing some really good news that I want to point out to you in here as it relates to employment data is that Wyoming had an estimated 16,000 hires in December 2022, which was up from 14,000 in 2021, still below the 18,000 in December of 2019 prior to the pandemic, but we are definitely heading in the right direction in that regard. As well, I believe it was this month, we had an additional 6,700 jobs or people moving back into the workforce. So when we get the question around the state, where is the workforce? They are starting to come back into the workforce. So I just want to make that really, that good news. I want to put it out there and shout it from the rooftops if I can. I would also like to recognize that today is National Workers' Memorial Day. That is the day where across the country we memorialize all of the workers across the country that have lost their lives or been injured on the job, and recognize them and their sacrifice for our benefit and for the benefit of their businesses. And everything that we do, or a lot of what we do in our agency, is safety related and is aimed at protecting those workers and doing everything we can to assist businesses to make their businesses more safe for those workers. Additionally, I also wanted to let you know, I believe it was last year, this legislature passed legislation that allowed our labor standards unit to accept complaints from our military department for discrimination and harassment grievances. We have rules were put into place. We've thus far had 5 complaints. I'm happy to report that I believe we've had 6 complaints, all but one of those have been resolved informally, which is the military process. You can go an informal process and then you can go into a more formal complaint process. And so I think that process is working very successfully. I think it is being utilized. We're working on a few things in that regard to make it, to communicate it better, but I think that was a very successful outcome for that particular piece of legislation. An additional thing I wanted to make sure that everyone is aware of, as you know, because I think all of us shouted it from the rooftops every chance we could get, was we had a buildup of funding in what we call our 528 fund. That is the fund that is investment money that comes off of a state workforce unemployment insurance trust fund. Those funds kept building up because we weren't sending them out for training dollars the way we should have been. We had kind of cracked down on this training fund program that we had. Recognizing that fund was building up and recognizing that businesses across the state really right now needed that money out there to build up their workforce, to train their workforce, and for those new employers coming into the state, they needed that money to train a workforce so that when they opened their doors, they had an existing trained workforce. So we changed some of the money, some of the funding that we had available, and dramatically increased the dollars available to those businesses out there. I'm happy to report that was wildly successful. We had the numbers that we saw in internship and internships across the state, as well as training of existing employees, just shot up the roof. So much so, we had a budget of, over a span of 2 years, we were going to spend $4 million. We've spent that plus some in 1 year because of the need out there. And what we've heard from employers is that the benefit of getting interns into their businesses, and we're talking interns, not only high school interns, but interns at UW, interns, just individuals interested in their industry, getting them in there and teaching them about their industry so that they can get to know the intern gets to know them. And then you've got, and the way they were able to keep those interns on then after that internship in their business. The reports we've gotten from business has just been phenomenal. It's been such a valuable program for them. We did spend our money down though, much quicker than we thought. So this past month, we paused that, took a look at what our funding trends were, took a look at the amount of money we felt we had left, because it's all a reimbursable program, so that we don't ever actually know exactly how much money we have, because we only reimburse after they've fully received all of that training or fully gone through that internship plan. So we paused our program to look at where we were at, and we're opening back up on Monday with some tighter parameters around some of those programs to ensure that it's an ongoing, fiscally responsible program. But it is opening back up. We're looking forward to doing that. We're hearing again from business, they're chomping at the bit to have that opportunity again. So stay tuned for that. It's been a great program. Additionally, ARPA opportunities. We've gotten, as you'll recall, 2 years ago in Senate File 66, the legislature provided workforce service programs with $10 million to do a variety of things, whether it was pre-apprenticeship, it was targeted healthcare, targeted childcare, some economic development opportunities and others. We are going, as you heard it yesterday, going through the process of getting those proposals approved. It has been time consuming, and that is to ensure that those monies don't have to be eventually paid back. We want to make sure that we're fitting within those ARPA confines. So we're just now starting to get the approvals for some of those programs. So we're moving forward with a targeted healthcare program that I think is going to be phenomenal. What it is essentially going to do is we're hoping we will have 300 individual students across the state that we can provide up to $10,000 to get that 2-year degree program. And those are going to be the individuals that'll be going into, we're hoping, into EMT, EMS, some of the technician type of programs that start them down that road into healthcare. So we're pretty excited about that and that program. We're hoping to start then in the spring of 2024. Another one is our pre-apprenticeship program. Again, that's that's the CTE apprenticeship skills building kind of program for ages 16 to 24-year-olds that we hope to start them down that road into skilled work, skilled labor that we all recognize that we need so much more of, into then stepping into those apprenticeship programs that we're also building up. We just today submitted another grant application to the Department of Labor for apprenticeship funds. And we've got a really fantastic apprenticeship team that is building those apprenticeship opportunities out there as fast as we can get businesses interested in them and building them, helping us build them themselves. So we've got several other ARPA opportunities we're looking at. We're not quite as far along on them as we would as these other ones, but we're working on them. Current opportunities, grants that we've applied for, that we've received, that we're very excited about. First one I want to mention to you is called the Pathway Home 3 grant. That was a $3.9 million grant from the Department of Labor. We call it our Career Compass program. And what that is, it's a whole untapped demographic in Wyoming for workforce. And it's working very, very closely with the Department of Corrections. And I want to thank and recognize the Department of Correction employees, Director Shannon, for all their help with that. We will be working with individuals that are justice involved and incarcerated individuals who are close to their release time. We'll be working with them on setting up resume or helping them build their resume, building those soft skills. How do you get into an interview and talk about your incarceration? You don't want to hide it. It's there. How do you deal with it? How do you discuss it? We'll also be helping them get some training before they even walk out the doors, or what if they want to go into education. We'll be assisting them with education, but it's starting before they even walk out the door, which has not happened before. So we're pretty excited about that as well. We also have an unemployment insurance equity grant, $2.2 million. It's going to help us make unemployment insurance application processes much easier. Plain language, opportunities to just use your cell phone for it. And we've not had those opportunities in the past. So that's going to be a pretty critical thing for those individuals. We also have a quality jobs equity strategy and training grant, which again will help serve individuals with training and support services to help them find employment in our sector partnership industries across the state. So another great one out there. We're also looking very closely at the IIJA, the Infrastructure Jobs Act, where they've got a lot of opportunities there. So we'll be working with our partners across the state for workforce opportunities with some of those infrastructure jobs that are going to be coming to the state from that. We're on any number of work groups. We're working actively with WIP. That is coming together so well. It is such a wonderful collaboration of education, K through 12 education, community colleges, UW, the Business Council, and workforce. And I think what you're going to see coming out of that WIP initiative are going to be some incredible opportunities, some incredible work across all of those different segments of our agencies coming together for, since my time here, coming together for the first time ever to really recognize how our activities synergize and work together for workers and businesses across the state. That is very quick, and there's a lot in here. Please take a look at it. We're happy to answer any questions you might have, but I wanted to just throw out some things to you and then be available for any questions you might have.
Mr. Chairman.
Go ahead, Senator.
So the money is running down, and yet we've got a lot of things happening in the state. where we need to put people to work. I'll move into the southwest part of the state. Western Wyoming, the community college is trying to get things geared up, and they're going to take it into their own buildings, but let me move just a little bit north, an hour north of there. I got a community that's probably going to cut a ribbon next month on a massive project. They don't have the crafts. They don't have the craft trades. They need to get those trained. They're actually talking about moving a training center into that community. Do you have any type of program that allows matching or allows help? Because they need to get these people up and running because they're ready to start construction this summer. So where are we at with that?
Mr. Chairman, Senator Dockstader, we do have funds for that. Again, we've had to back those funds down a little bit because of our funding resources, but we do have it's called a pre-hire grant opportunity there. What that does is it will help train those individuals before they even walk in the door for that business. So please, I will actually have them reach out to you and get you some information on that. That's exactly what that grant's for.
Thank you. Mr. Chairman, that'd be great. Thank you. We're ready to go to work. Thanks.
Absolutely.
Representative Hornock, then we'll go to Senator Hutchins.
Thank you, Mr. Chairman. Currently, how long does the unemployment insurance last for an individual who applies?
Is
Okay,
it
let
still
me-
26 weeks? Is it the same question yesterday? Unemployment insurance? Yeah. I believe it
Okay.
was 26 weeks was the answer yesterday.
Mr. Chairman, that's correct, 26 weeks. 26 weeks.
A follow-up, Mr.
Yep.
Chairman? Do you have statistics that you can provide on your Wyoming at Work program where somebody who, I guess, files for that unemployment or goes into the Wyoming at Work program, puts their profile up on that? Do you have statistics for the rehire rate within that program for people who are have a profile?
If you do, Director Cooley.
Mr. Chairman, Representative Hornock, our Wyoming at Work program is the program we have where businesses offer or put on there what their position openings are. So individuals that are on unemployment, they can use that opportunity to get a job, but they can look on Indeed, they can look on all these other job sites. So I would not be surprised if we could pull up those records for you, but that doesn't mean that that's the only place that unemployed individuals might get a job from, is what I guess I'm trying to say. It's not going to give us the bigger picture.
Go ahead.
Mr. Chairman, thank you. So I guess I'm curious about that bigger picture. How many people go through the full 26 weeks on unemployment insurance versus how many people are we interjecting back into the workforce during that 26-week period? And especially in relation to the Wyoming at Work program, how effective has that specific one been? I understand there's other Indeed and whatever, which helps.
Yeah.
Obviously, but just curious about the effectiveness of that, as well as how many people start on unemployment insurance versus would finish the full 26 weeks or are injected back into the job market during that 26-week period. I'm curious how effective we're being at the full unemployment spectrum.
Mr. Chairman, Representative Hornock, and I had this down for the last legislative session because these exact questions came up. It's a small minority that go the full 26 weeks. I will first say that. As I recall, the majority of individuals that are looking for a job find it in that first half of those 26 weeks, if not sooner. I will tell you, the minimum amount you can get on unemployment is $40. The maximum amount is $560 a week. So it's not a lot of money for individuals to help pay costs. There is a real incentive based on those amounts for them to get out and find a job. Now, as to the Wyoming at Work program, I'll get some statistics on that. We are currently under contract now with a new system, it's an MIS system, Management Information System, that is going to upgrade that Wyoming at Work program because we've recognized there are issues with that program. It's clunky, it's hard to use. It's hard, in fact, in particular, for businesses to put their jobs up there. So that is one of the focuses that we're going to have with this new MIS system, is working on that system in particular, so it's easier to use. But I can get some statistics, I think, around the success of that particular program.
One more.
Sure, one more.
Thank you, Mr. Chairman. I'd appreciate those statistics. Yeah, I'm just, it's one thing to read how many people are, some of these statistics. It's another thing to see how effective our programs are being, not just how many people are unemployed, unemployment statistics. So I'm curious as well to know if you have any thoughts about our current workman's compensation program, and if there are any ways to that we can, with legislation, be a little bit better with that. I mean, it does cost, in this last year, workman's comp went up $2,000, across the board for businesses per employee. Just curious if you have any thoughts about how we can better utilize that program, what we can do with legislation to minimize costs on businesses in that particular structure.
Thoughts, Director Cooley?
Mr. Chairman, Representative Hornock, we have a number of thoughts, a number of options that we're looking at, because that's one of the very questions that the JAC is asking. From my perspective, when we're comparing ourselves to other states in particular, our state only requires workers' compensation insurance for extra hazardous industries. When you look at some other states in our surrounding area, what they've done is they've come in and required it for every business in their state. So just like any insurance program where you are spreading out that risk to not only extra hazardous, but you've got retail workers, office workers, where the risk is less, and so they're less injury. You're spreading that risk out, and you're going to bring those premiums and those costs down. That's one way to do it. There's a trigger law, and I'm not real familiar with that. There's if one of the things we're looking at is once that fund gets to a certain amount, it triggers a reduction, or it triggers a plateau of the rates, for instance. So there's a lot of different options. If it would be beneficial, I'd be happy to have Jason Wolf, who's my administrator in that area, get you some of those options, just some ideas to start looking at and considering. Be happy to do that. There's a number of options, I believe, out there. So, but I also would like to mention to you and to the committee, if you're not already taking advantage of them, we do have a number of programs that help you reduce those costs. They're safety, I forget the terminology, they're safety programs you can implement that help you bring your costs down. So that's another option for you to consider, and we'll get you information on those as well.
Thank you. Senator Hutchings, still have a question?
Yes, sir, I do. Thank you so much. I'm hoping I'm not a Debbie Downer, but when I go to places like to get my tires fixed, my oil changed, talk to different employers, they're always complaining about the employee. People just don't want to work. They have a different work ethic than I do. I mentioned just the other day, a businessman said to me, a young lad working part-time comes in and throws him a little sheet of paper, throws a little sheet of paper on his desk. These are the days that I'm taking off. It's like, whoa, you're a part-time worker, you're going to be here for a little bit. You're demanding not just 2-3 days, but a lot of days off. And we just can't get good workers. So for you, are you hearing this?
Mr. Chairman, Senator Hutchings, absolutely. I'm hearing it, and I don't know if it's I hear it talked about in terms of the different generations, but I don't want to generalize that. What I think is going on, possibly, potentially, in my own opinion, we're in a different dynamic in the workplace now, and we've got more jobs now than we had available than we had before the pandemic. So just like sometimes you have a buyer's market or a seller's market in real estate, right now we have an employee market where they can, if they're not happy here, they can walk down the street and find something fairly quickly elsewhere. So I tend to think in pendulums. I think we're in a pendulum swing, and I think it'll come back to where that's that kind of an attitude will lessen. But you also have individuals now with a whole new industry they can walk into, with a gig industry. They can go deliver for DoorDash. They can get online and be an influencer. There's a lot of other alternatives for them. So I don't think this idea that we will have 5 interviews set up, and I've heard this from a lot of people as well. 5 interviews set up, and we have people, 3 or 4 of them, no show, no call. That was unheard of to me. And it's not unheard of anymore. So it's a different dynamic in the workplace right now. And I don't think it's any one thing. It's a number of things that have added up.
Oh, Mr. Chair, quick follow-up. When you have these training programs that you spend, or you've gotten so many grants for, work ethic, is that part of it? I remember an employee just come in at 10 o'clock every day. And it's like, what's going on with this person? And everybody else, 7:38. When she was asked, she says, no one ever told me what time to come in. So I'm coming in at 10. It's like, whoa. So the work ethic, are you guys also training in that respect? There are certain things that are required, your dress, your attitude. You're not gonna come in to get a vacation the moment you walk through the door. You can't set your own hours. You know what? My son has a baseball game and I'm going to that. I'm not coming to work. All these no-shows. How are you incorporating that into your training, if you don't mind me asking?
Mr.
Go ahead.
Chairman. Senator Hutchings, those are the soft skills that we need to be training. In our workforce centers, we've got a lot of modules that when individuals come in and they've lost a job, those are the types of modules that we have them sit down and go through and train in. With this Pathway Home grant that we've got for individuals that are incarcerated, those are some of the modules that we're teaching for them too. Just showing up on time for an interview, showing up on time for work. How do you answer interview questions? How do you dress for an interview? Those are all soft skills that are being taught in those modules. We don't personally teach them in the training because with the training fund programs that we're funding, because those are trainings that, for instance, if somebody has a welder and they want to send the welder to get this additional certification, those are the types of things that we're paying for with those programs. Thank you.
Yep. Any others, Representative Trujillo?
Quick and short, Mr.
That's what
Chair,
they all
thank
say,
you.
but go ahead.
You brought up unemployment and the no calls, no shows. What is the policy? Does the department follow up with, the person collecting unemployment, and they put on their piece of paper for the week, I have these 5 jobs that I'm going to go to or, interview, and then they're the no-show, right? So how does the department handle that?
Yes.
Go ahead.
Mr. Chairman, Representative Trujillo, that's an excellent question. We were just talking about that today. We have individuals that are, because when you're on unemployment, you have a certain number of times that you've got to be applying for jobs. It's an ongoing process. It's a reemployment process for you to get out there and find another job. So if you're telling us and you're certifying you called this, you applied for this job, we're following up on that. I don't know that the follow-up is as far as the interview process and that, but that might be a good idea to do so that we don't have those no-shows. But what we need to impress upon businesses out there is if they have an individual that they know is on unemployment, that's calling them up and just asking them about a job or filling out an application and then indicating they're not really interested in it, they just needed to do it for unemployment, we need employers to report those individuals to us. That is fraud. We do follow up on that and we do take action. That makes them ineligible for unemployment, and we have to know about that.
Okay. Thank you. And on the soft skills, that's taught through a module on the computer?
Go ahead,
Mr.
Director.
Chairman, Representative Trujillo. Yes, those are modules that we have on our computers there in our workforce centers. That's some of the information they can do as they work with. They have an individual they'll work with in the workforce centers around the state, and those are modules that they can sign up and do right there. Or I believe they can do those at home as well as they're working through this process. Yeah.
Thank you.
Representative Hornock?
Thank you, Mr. Chairman. So I appreciate that you are asking employers or companies to report somebody who doesn't show up to a job interview. Is there an easy mechanism to do that? How would an employer actually do that? Is there something on your website? Is there an easy form to fill out? How does that happen?
Mr. Chairman, Representative Hornock, there is a fraud button on our website. You get in there, you can't miss it. We make it very easy, and we've got to know about it in order to follow up. So please, spread the word.
Senator Hutchins, question?
Follow up on that question. Do you have statistics on how much fraud, waste, and abuse there really is out there? How many businesses, because I know there are people, I've been told, that will say, oh, go apply over there. They had a job opening, but now it's closed and you'll get turned down so you can continue on the program. There's ways to get around the system. So how many cases are you finding out there?
You talked briefly about you research all this and keep track?
Yeah, Mr. Chairman, we do keep track of that, and I don't have it right here, but we'll get that for you. We've got a good fraud team that tracks that down.
Anything else? You're now officially off the hot seat,
All right,
Director
very
Cooley.
good. Thank you so much.
Yep.
Waiting.
We have Family Services online, but since they're online, we'll go ahead and have Health come on up. Welcome back, Mr. Grossman, Mr. Fuchs.
Thank you, Mr.
You do have a
Chairman.
presentation that's in the packet where you want some legislation that's about 10 words. And if anybody wants to just make the motion to have that drafted for our next meeting, I'd entertain that, but otherwise we can. have their presentation. All right, so the motion, Chairman Baldwin, is the red language on slides 195 and 196 about 60 days on a claim for payment and response time, and the failure to obtain required prior authorization. We should make that into a statute in 424204E4. That's the motion?
That's the motion.
And the second? Anything else you want in it, not included on the slideshow?
Mr. Chairman, nothing else to add.
Okay, all in favor of that motion for bill draft at our next meeting with that language that came out to you all 2 weeks ago that you could review? All those in favor say aye.
Aye.
Any opposed? Great. Any other updates you want to give, Department of Health?
Mr. Chairman, Lee Grossman, State Medicaid Agent again. At the risk of incurring the further wrath of this committee, we do have just a few updates, but we'll be very concise. And I'll turn it over to my colleague, Franz Fuchs.
So, Mr. Chairman, members of the committee, again, my name is Franz Fuchs, Policy Analyst, Department of Health. Director just wanted us to communicate a couple updates, kind of as the major challenges the department's facing over this next year. The first major project that we're implementing is the behavioral health redesign. And some of you may have heard this. There's like this 3-branch approach. There's this diversion pilot happening in Gillette, or supposed to be happening. There's looking at additional psychiatric resources we're trying to bring into the state through telehealth. But basically, it's all sort of connected in this redesign, which has been the product of at least, I think, 3 pieces of legislation passed over the past couple of years by this body. So we are in the process now of really figuring out details internally and trying to figure out how to make the sausage. We're going to be incorporating a lot of feedback from our stakeholders and our provider groups on that. The devil is in the details in many ways. But that's one of our major challenges this year, because the turn-on date for that is July 1st, 2024. So the second major challenge that we're facing is on our facility side. As Director Cooley mentioned, the workforce is tight. We are experiencing that very acutely on the nursing and nursing adjacent front. So we were still having difficulties recruiting at the state hospital, the Life Resource Center, and even the new VA nursing home in Buffalo. So we're pushing back the opening date just because we are really having trouble getting bites on our ads for CNA level workers. So we'll keep pushing. We hope that the pay adjustment that you all approved will help with that recruitment process when it comes into effect. But at the end of the day, the workforce is pretty tight, and I think I don't have to mention that to any healthcare provider in this room that may still be in this room. Our final update is on Medicaid front, so I'll let
All right, Mr. Chairman, just a few sort of omnibus updates. During the last legislative session, you all passed a host of impacts on the Medicaid program, primarily related to reimbursement rates. So I wanted to give a brief status update here. First, on the implementation of 12-month postpartum benefits for pregnant women receiving Medicaid benefits, we're on track to implement that July 1st is when that will go into effect. Also going into effect July 1st is additional funding to start pulling people off of the wait list for the Developmental Disability Waiver Program. If you recall, there was funding to essentially cut that wait list in half to where the maximum waiting time would be approximately 18 months is the way that'll shake out. Those funding letters, I'm pleased to report, have started to go out to families on that wait list, and that those services will kick in again July 1st. Also, a July 1st effective date is a host of various rate increases. These include for nursing facility providers, durable medical equipment providers, and also home-delivered meals for seniors and people with physical disabilities who receive services on the Community Choices Waiver Program. April 1st, we implemented rate increases for dental providers, which we were pleased to do. And last but certainly not least, we are on track to implement increases for providers of developmental disability waiver services, and that is slated for October 1st. Reason for that October 1st date is the various requirements in terms of getting federal approval is much more cumbersome than some of those others I mentioned, and all have to occur on a prospective basis. With that, my colleague and I would stand for any questions from the committee.
Questions committee, Senator Dockstader.
Well, first program again, July 1st, telehealth, mental health for Campbell County, right? And then see how it goes and if we want to expand it?
Mr. Chairman, Senator Dockstader, the July 1st date will be 2024 for the overall behavioral health redesign. And that's sort of the reconfiguration of how we buy behavioral health services with our general funds. And so that entire redesign will support efforts like that pilot program. That pilot in Gillette is being driven by the judicial branch. So we're not in the cockpit necessarily on that, but we're going to be there to support them with funding those providers, trying to incentivize those providers to take those clients and the like. But the July 1st date I mentioned was 2024 to turn on the entire redesign.
Other questions? And I do think at our next meeting, we'll probably give you a full half an hour to talk a little bit more about an education for the committee, especially the new members, about all the programs at a higher level, the Department of Health. Representative Yin.
Mr. Chairman, not a question, but just a comment. I think it was really great to hear all the providers say that working with the prior authorization process with Medicaid is actually not bad. So when it comes in comparison, so I think that is a win, and for a well-managed program.
Thank you. Other questions for the department? Seeing none, thank you much. We'll see you at our next meeting, and you're putting together a tour of the state hospital for us. Hope you're aware, and we'll have that bill drafted, can talk more about it and the need at that point. With that, drive safe. Director Schmidt, welcome to Labor Health. You're still at the office. We appreciate that. So are we. Floor is yours.
Thank you, Mr. Chairman, Mr. Co-Chairman. My name is Corin Schmidt. I'm the Director of the Wyoming Department of Family Services. And am I cleaning up? Am I the last one on the roster?
We still have public comment, then it might get a little crazy. So yeah, we might be here a while, but take as much time as you need.
Okay, great. Well, thank you. And thanks for the opportunity to give you some updates on department activities. First, I just want to celebrate a few of our successes. Last week or the week before, we've received notice that we are the #1 child support program in the US, which we're very excited about, but even more exciting, this is the 10th year in a row. So there's a series of outcome measures that all programs report. And then basically through some analysis, they indicate which of the state programs, the order and ranking of the state programs. So we're very excited of that partnership with many of our many local attorneys and caseworkers, and certainly our staff through DFS. Another celebration, and this is a little bit bureaucratic, but important to us. Every few years or so, we go through what's called the Child and Family Services Review. And this is a federal review because we receive federal monies for our child welfare program. And you'll hear us refer to 4E, 4B, some of those types of terms. We are about ready to go through our review, but we just demonstrated to the federal partners that we can do our own review. Previous reviews required that the federal government would bring their staff in and do the review of our cases. We documented and showed them in practice that we are able to do our own review. And why this is so exciting is because it really gives us an opportunity to look deeper into our own cases and to really do a much more comprehensive quality improvement effort, rather than just looking or waiting to understand what the feds thought. So that actual review, we've just been practicing. The actual review will start in November and complete in January. And then one of our smaller programs, but a program that affects a good number of people, is our central registry processing. So child care facilities, long-term care facilities, sometimes hospitals, will ask us to look at our central registry, which is the registry that records anyone who has been substantiated of abuse or neglect of an adult, a vulnerable adult, or a child. We have changed that into an electronic process. And at this time last year, what took 8 days is now taking less than 1 calendar day. That's been really important to us, especially as Director Cooley mentioned that employment's important, turnaround on employment's important. And this is something that many child care centers need to have so that they know that their staff have not been substantiated of hurting another child. And so getting it down to 1 day has been a tremendous improvement. Some program updates. As with a lot of other programs, because the public health emergency has been lifted, we're starting to close down a few things that we've had going. First is the Emergency Rental Assistance Program. That program is slated to end June 30th, 2023, so just in a couple of months. We've seen applications go down substantially, or extension requests go down substantially. Up to this date, we've served 17,000 households, provided $105 million in direct rental assistance, of which 80 million of that went directly to landlords. 20 million went to households, and about 5.6 went to utilities. The average assistance to any given household was about $6,127. So that program was very much a COVID program. It's coming to an end. We've been working closely with our community-based organizations on the last of the funding that they have to provide a lot of case management to families who are going to be affected by the end of this program. Our Housing Assistance Fund, which is the mortgage support, is still in play. It does not expire till 2026, but there is still quite a bit of money in that program. So we're continuing to provide that service for eligible applicants. In our SNAP program, our Supplemental Nutrition Assistance Program, some of the requirements that had been lifted under COVID will be going back into place over the course of the next couple of months. One of those is for able-bodied adults without dependents. So when we think about our SNAP population, we have a very broad population of different requirements for eligibility. There's a group of people called ABODs, and that conversation comes up frequently, but it's the able-bodied adults without dependents group. And they are required to perform work requirements. So we partner with the Department of Workforce Services to get those folks engaged in work. During COVID, we were not screening for eligibility, similar to what Medicaid was not doing. Starting July 1st, we will. So we'll be ensuring that those eligible clients are indeed either working or engaged in some sort of work activity, and then their eligibility is limited based on their financial resources. Also for students, there were a couple of waivers to some of the requirements for students. One is that students weren't required to report an income in order to receive SNAP. Now they will. So we'll be looking at their financial status. And what that really tells us is that they are doing some level of work. And also the number of, another component of the eligibility was, were they eligible and were they active? And under COVID, they did not have to be active participants. They just had to be eligible participants. With the lifting of the COVID, we will be looking at both. They will need to be actively engaged in school and also eligible financially for SNAP. So just closing up a few of those programs. Some fun updates. May, starting Monday, is National Foster Care Month. The governor will be signing a proclamation next week, and we have celebrations scheduled throughout the state. We'll be rolling out kind of a new campaign. When we talk about foster care, I think most people really think about some of the smaller kids, the infants and children that come into protective custody and then are placed with either relatives or stranger foster care. And what we really need are foster families who are willing to take care of adolescents, 12-year-olds, 13-year-olds, 14-year-olds, and on up. Those are the children that we have the most difficult time placing in a family setting, and oftentimes then are going to some sort of congregate care or institutional setting like a group home. We really believe those children also deserve to live with families, but they are a tough group to serve. So we'll be focusing our foster care recruiting campaigns really on those families who are willing to take a little bit of a risk and understand that it's a little bit of a tougher kid sometimes. They're older, bigger, but what foster family setting can do for those kids is tremendous. So throughout May, please look into your local DFS office for events and recruiting ideas. We continue as a whole throughout the whole agency to look at IT modernization. A handful of years ago, you all generously gave us money to make some major updates to our two bigger systems. The first one is what we're calling WyoSafe. That is our social services case management system. The system we use right now is called YCAPS, and that's where we record all of the casework for abused and neglected children, juvenile delinquents, and children in need of supervision. That system is archaic, it's built in the 90s, and really has very little functionality that we would need today to give you better reporting to understand outcomes around the families that we serve. But that project, WyoSafe, is going, and it's going strong, and we're really happy to see the progress. We'll be providing a more thorough update to joint appropriations in July. We also received money to do some modernization to our eligibility benefit system. It's the system that we use for SNAP, TANF, and child care assistance. Basically, it documents and records a person's eligibility and helps the workers then manage those cases throughout the life of their experience or eligibility with DFS for those programs. That system is going through a little bit of a different process. It's not a wholesale replacement like we're seeing with WyoSafe. Instead, it's really modernizing bits and components of it. It lives on the mainframe right now, which is a very expensive place for it to live. So the first task is kind of reconfiguring it so that it doesn't have to sit there, that it can sit on a platform within our own system. And then from there, we'll do some of the cool things like creating portals so that clients can apply online and those basic kind of modern expectations we have. But the system that was built in the 90s and currently doesn't have it. Some of the legislative updates that we can provide. We're in conversations right now with our social service district managers around the $500,000 prevention dollars that was appropriated to us. Yes, thank you. And we're really looking to local ideas and efforts on how to best use those prevention dollars. This is a continuing conversation we've been having about the value and the importance of reinforcing community supports to work with families and children at risk. We believe that children, if they can stay safely at home, that's the best place for them, but that oftentimes they'll need additional supports. So working with our local our youth and adolescent service providers, our group homes, our crisis centers, and thinking more deliberately about what they can do locally to create support for families through family therapy, mentorship for kids, and those types of prevention efforts. So we're really excited about that. And I think knowing how creative we can be at a local level, I expect some really cool stuff to come out of that. We're also getting close to finishing the plans of safe care rules. That's tied back to the legislation that was passed about developing a plan of safe care for discharge for a mother and an infant and their families if the infant was born substance exposed. So we have had a series of meetings with partners. Those meetings will continue so that we can have the broadest based approach to input on the set of rules. And we expect that they will be done and ready for final promulgation on July 1st. The program really doesn't take effect until January 1st of 2024, but getting the rules into place is going to be important for the other work that we'll need to do to create referral systems, to create guidance and consistency for plans of safe care participants throughout the state. High needs children, that is an effort that's also being addressed through the Mental Health and Vulnerable Adult Task Force. We received some ARPA funding to serve those children better. The ARPA funding really kind of set up the conversation as a pilot to look at it from a research perspective to see what those additional dollars and the flexibility those dollars can do to get high needs children and youth into services quickly, or to be able to support them better while they're waiting for the appropriate level of care. High needs children at any given time, we have about 12 to 15 kids who are incredibly difficult to treat. They're young men. They are high behavioral needs. They're oftentimes violent, severe mental health issues, and then even a handful of them with intellectual disabilities. So the combination of those three characteristics really make it difficult to find a safe and therapeutic placement in the state. We're working closely with all of our providers on innovations. Some of our providers have done some pretty neat things in terms of being able to help kids who are getting a little bit older independently live with a lot of support before they become adults and have another system that they can participate in. The preschool rules, so we all had a long conversation about preschools, and those rules will be finalized in the next few months. They're with me right now for review. We are going to informally shop those around with folks who had a lot of conversation, a lot of interest in them, and then they'll go to the formal rule promulgation process in the next month or so. And as with everyone else, we have a lot going on. It is 6:03. I know I'm the last person other than public comment, and always appreciate a chance to speak with you and to update you. However, I think I'll end my comments and then be available to you if you have any follow-up questions.
All right, questions for DFS. Representative Hornock.
Thank you, Mr. Chairman. Thank you, Director, for the work that you do, sometimes difficult, sometimes satisfying, sometimes not satisfying, but appreciate that. I'm curious, within your agency as a whole, do you still have any employees that are actively working from home? And then I'm curious, if you do, what the percentage of those people are? Director Schmidt.
Mr. Chairman, Representative, yes, we do have employees who are actively working from home. We instituted a hybrid model for our services. In our agency, we have staff who can do their work from home and staff who cannot. Each employee, through their supervisor, the options for telework is discussed with them. And then they decide on what's the appropriate number of days to work from home versus working from the office. So I couldn't give you an across the board how many people are working how many hours in any respective place, other than to say that we have individual telework agreements with the staff who can work from home. And then from there, that's managed and monitored by the supervisor and the division's leadership. What I can tell you is at the state office, where the work is a little bit more conducive to telework and where we have many state staff located throughout the state, there's a lot more telework from basically Cheyenne. But in our local offices, so much of what they're doing has to be done in the office. So you see less telework happening there.
Okay. Other questions for DFS? Representative Penn.
Thank you, Mr. Chairman. Director, when you were going back to when you were talking about SNAP benefits and the programs, could you give me some idea on numbers, what the able-bodied adults, how many able-bodied adults were on the SNAP program prior to COVID, how many currently are, and how many do you anticipate are going to be found not eligible once, you know, we can start disenrolling people? And also, if you would be willing to get us a copy of what the eligibility requirements are for able-bodied adults to be on the SNAP program. Thank you.
Go ahead, Director, if you have that information available.
Sure, Mr. Chairman, Representative Penn. What I can tell you is in March of 2023, there were 3,128 ABODs receiving SNAP benefits. The timeline for them starts over. So July 1st, in order to continue eligibility, there has to be continuous employment or trying to achieve employment. If a person does not meet that expectation for 3 months, then they become non-eligible for SNAP. So we are going to start the process of rechecking eligibility. And at that time, it's going to be a little bit before we know how many do we expect to fall off. So we can't really give you an accurate number of the number that we'll expect to fall off because we're starting from scratch. We're starting from zero on July 1st.
But perhaps at a subsequent meeting, we could do an update on that tracking by, let's say, September and get a better number?
Absolutely,
Representative
Mr. Chairman.
That'd be great. That's it. Thank you.
Other questions for DFS? See, Representative Trujillo.
Thank you, Mr. Chair. I'm sorry if I missed this, but on the requirements for juveniles to give their pay stubs if they're working at McDonald's 20 hours a week, is that a federal requirement or state?
Director?
Mr. Chairman, Representative, I'm not sure I'm understanding the question about the juveniles. If you're talking specifically about SNAP, showing, I'm sorry, could I maybe ask for a little bit more clarification?
Yeah, well, you said students have to show their income. So is that a federal requirement or state requirement?
Mr. Chairman, Representative, thank you for that clarification. When I say students, I mean higher education students. So these are people who are on SNAP because they're receiving higher education. Those are the people that, yes, we would require that they show us that some sort of level of income. We typically use what's called as the FAFSA, the financial aid form. I'm not sure if we require pay stubs, but we could certainly give you more information about how we do that.
Is it a,
Thank you.
is it a federal statute that's requiring you to do that, or is it a state law we have in place, Director?
Mr. Chairman, that is federal law, federal requirements for program participation.
Seeing no other questions for DFS, thank you for waiting with us tonight, Director.
You bet.
Enjoy your weekend.
Thank you and safe travels to everyone.
I guess any bill draft requests for many of the agency things you just heard before I go to public comment? Okay, seeing none, we're going to open public comment. Still have some people here in the audience. Don't see any online. Ms. Declever, you're just here for the day to join us, huh? Nothing further from the governor's office? Blue Cross? Okay. I was kind of informed we might have a couple people coming forward to public comment, but maybe they didn't want to wait till 6 tonight. So anything else to come before the committee? No, you do. Representative Ward.
Thank you, Mr. Chairman. So yesterday I mentioned a topic that I wanted to see covered, that at least 6 of us wanted to see covered, and I'm bringing that up again now. That was medical freedom concerning masks, vaccination, and testing. So can we discuss adding that to our docket?
So I guess it's a motion, I'm guessing, and it would be to kind of bring back your legislation. Is that the starting point for potential committee sponsorship? Maybe because either make a motion or a little more what you're thinking.
Sure, I move that we discuss how we can ensure medical freedom for the people of Wyoming. House Bill 66 and House Bill 143 would be a great starting point, but we don't have to start there. I'm open to other means of securing medical freedom from forced vaccination, forced masking, and forced testing. And I know at least 6 of us wanted to talk about that.
And so let me check with LSO because I don't believe that's on our interim topic list. So it would require this committee to have an affirmative vote to take that request to Management Council and have them designate it to this committee. Would that be the process that, as you are aware, Anna?
I believe so, Mr. Chairman.
Okay. Just make sure, Speaker or Senator Barlow.
Thank you, Mr. Chairman. So whether this committee approves this type of request, any member of the legislature could still put in a request to Management Council as an individual legislator or as a group and ask for that consideration. So it doesn't have to come from a committee, it can come from any group of legislators. Thank you, Mr. Chairman.
But for the motion on the table to discuss medical freedom, is that the proper terminology, and use those 2 bills as a basis?
Yes, to be clear, I am making that motion.
Okay,
Thank
is there a
you.
second? Seconded. Any discussion on that motion? And so again, the motion would be to, as a committee, request Management Council, I don't think there'd be additional funding, but agreement to allow us to pursue an interim bill along the lines of medical freedom with those 2 bills as our starting place.
Mr. Chairman.
Representative Yen.
Mr. Chairman, thank you. I mean, a question to the bringers of the motion. How much time do you think that it will take the committee to work on those bills, plus comment from the public, et cetera?
Representative Ward, thoughts?
Thank you, Mr. Chairman. I would anticipate 1 to 2 hours.
Further discussion? All those in favor of requesting, having LSO draft letter to Management Council requesting authority to pursue a medical freedom topic based on those two bills, please say aye. Aye. Opposed, say no.
No.
Then we'll see a show of hands. All those in favor, if you'd raise your hand. 1, 2, 3, 4, 5, 6. All those opposed, raise your hand. 1, 2, 3, 4, 5, 6, 7. Any other motions to come before the committee? Be happy to entertain them this time. Senator Baldwin.
Just real quick, Mr. Chairman, I would request that when we bring back that topic about services for the aging, elderly services, that we request the task force bring a presentation to us. They've been delving into this quite deeply into the PACE and senior centers, et cetera, and I would ask that they bring something to present to us at that same time.
Some kind of an overview on the governor's task force when it comes to kind of a plethora of issues we talked about the last 2 days. And maybe we could do a presentation for 15 or 30 minutes on kind of all the areas the executive branch is working. We don't want to duplicate efforts, but we certainly want to be on the same page if there's statutory changes or appropriations that need to be made. I think we can just incorporate that as probably the agenda making process, because it's not necessarily legislation, it's just making sure we're on the same page. Anything else from LSO? I don't think we need a recap of the request unless you want to, Anna, but.
I think I have everything down.
Okay. With that, we will see you all in Evanston at the end of June. Have a safe drive. We are adjourned.